Uh, Thank you everyone for joining with us this morning with this troublesome time. So first of all, I would like to begin by acknowledging the Nanal people, the traditional custodians of the land on which we, the conference committee and all the participants are gathering here today, and pay my respect to their elders, past and present. I extend that respect to Aboriginal and Torres Strait Islander people here today. So in today's conference, as we are here, we have a scheduled program in lots of sessions. We have mainly 3 sessions: morning sessions, midday sessions, and afternoon sessions. In the morning sessions, we will hear from our Dean, Professor Russell. Then after Russell, Lyndall will come out with her message. And then the student presentations will begin at around 10 after their speech. And it will continue till 11:15 when we'll go to the morning break. And then again in the midday session, we will start 11:30. And then it will continue up to lunch break, that is 12:45. And then after that, we will have another last session at the afternoon sessions. And then Professor Michael will give his speech at 1:45. And then we will go towards the end of the conference and we will wrap up around 2:30. So that is the whole program we are going to have this morning. So before doing that, I would like to say that our session is going to be recorded. If you have any concern, please let us know. We want to showcase our conference for the later phase for the students and other like HDR, all of us, for the encouragement. So we are going to record these sessions. So if you have concern, please let us know. And other things like in the conference, we all are adapted with the virtual conference and meetings. So we know our etiquettes. So I don't want to mention that because we'll all know, but it will be good if some presenters will present. We will be concerned about muting our voice recording. And if we have any questions, yes, definitely. After each presentations, we have a Q&A sessions. In that sessions, please raise your hands up and one of our co-hosts will catch you and we will discuss. I would like to have the privilege to say that it's not a competition. We are here for sharing our thoughts, to mingle with these situations and know our research, know our struggle like that. We are not competing. We are just here for discuss our things, our thoughts. So let us begin. Is Russell here, Lyndall? Okay, so now I would like to invite Professor Russell Guering to piece his speech, and I am just inviting Russell. Thank you so much.
Thanks, Ripon. Thank you very much. I too acknowledge and celebrate and pay my respects to the Ngunnawal people of the Canberra region and to all First Nations Australians on whose traditional lands we meet and work and whose cultures are among the oldest continuing cultures in human history. I congratulate you all for ensuring vitally important events such as these go ahead, even when we're in lockdown, and it's an honour to be part of the proceedings. A wonderful thing about the pandemic is that everyone has heard of epidemiologists. Many can even pronounce it correctly. And more people than ever before know what sort of work epidemiologists actually do. And of course, epidemiologists have provided the expertise to help the world's leaders navigate through the last 2 years. A strange corollary, though, is that in the media and public sphere, we have seen a plethora of epidemiologists, whatever the collective noun might be, and perhaps even professionals of other sorts waging into the expert domain of epidemiology without perhaps always having themselves the training or expertise. Given that our university has been a leader in epidemiology and still is committed to being amongst the great universities of the world and driven by a culture of excellence in everything we do, and that we'll soon be rebirthing Australia's National Centre for Epidemiology and Population Health as a flagship school-level entity of the university with the autonomy and self-direction that brings, I want to tackle the matter of expertise in epidemiology and population health. It's a commentary that could be relevant to health professions more generally. I start by asking, what is it that would make an epidemiologist best in class? I'll offer some reflections not as an epidemiologist, for I am not. I'm a humble surgeon, but as an academic leader who values excellence and expertise, as someone who has admired many wonderful epidemiologists and public health leaders over several decades, and as your dean who has the greatest ambitions for you as graduates of the Australian National University. I'll start by suggesting that the best are recognisable by more than technical excellence and superior knowledge, essential as these attributes are. Although they're often senior, it is more than age and experience that distinguishes them. They're the colleagues from whom others seek advice because they make good decisions. They willingly provide guidance and support. Their actions match their opinions and their outcomes justify their practice. They appreciate the context and the drivers of doubt that confront any choice, and their advice is grounded in common sense. They provide mentorship for peers and juniors, and indeed are sought out to do so. We might say such epidemiologists are wise, and it's their wisdom that we admire. So what is wisdom? Well, it's a complex human trait that transcends generation and culture. It embodies elements of rational decision-making, general knowledge of life, empathy, compassion and altruism, comprehension of divergent values, emotional stability, insight or self-reflection, and the ability to proceed and progress in the face of uncertainty. For centuries, people have sought to understand wisdom and how to be wise. Aristotle, perhaps best known amongst the philosophers of wisdom, offered a particularly practical view. Being wise, he argued, requires the ability to see on each occasion which course of action is best supported by reason. And in doing so, a wise person lives well. To Aristotle, this ability has intellectual and moral underpinnings, grows with experience and time, and is determined by choice and acquired by habit. Just as one who makes good decisions in life lives well, we could say that an epidemiologist who consistently chooses the best course of action practices well. What is it then that makes them wise? Well, certainly competence and professionalism provide a foundation and are prerequisites. Competence encompasses the knowledge, the skills, the attitudes that are needed to be an epidemiologist. These include technical skills, such as statistics, analyses, applied epidemiology, and so on, and non-technical skills, such as decision-making, communication, collaboration and teamwork, management and leadership, and so on. Much has been done to define and teach and assess such competencies, and you won't graduate until you can demonstrate you have them. Professionalism refers to the moral, the cognitive, and the collegial aspects of working in the field. Professionalism includes such things as a commitment to honesty, to transparency of methods, and to accurate representation of data, even when your findings are inconvenient. And doing the right thing without cutting corners, even when we're tired and nobody is watching. It also includes how we work respectfully with colleagues, even when their opinions differ from our own, and how we contribute our expertise in broader public discourse about health-related issues. Now, neither incompetence nor unprofessional behaviour is acceptable. So I argue it follows that competence and professionalism are the minimum expected by peers, by regulators, and by the public. I think epidemiological wisdom is something more. The difference seems to lie in 4 additional attributes that together enable the wise epidemiologist to consistently choose the best course of action. These attributes might be superior judgment, rich understanding, few unjustified beliefs, and a strong moral compass. Let's look at those briefly, separately. The first attribute is superior judgment. At the core of most definitions of wisdom is the ability to judge truly what is right or fitting in any situation, and to perceive and adopt the best means for accomplishing an end. Even when confronted with unfamiliar challenges, appropriate probabilities and risks are considered and contextualised behaviours are fitting. So in our moments of indecision, we're likely to wonder, what would a wise professional do in this situation? Those who consistently make good decisions necessarily have excellent skills and situational awareness. They consider all the options and they thrive on detail and nuance. The best models and the best public health plans take into account specific characteristics of diseases, communities, macro trends, resource availability, probability of success. For example, I would pretend that the world was misled, perhaps, early in the pandemic by modelling that was based on influenza and not something more serious. The absence of alternative scenarios of a more serious pathogen, and because public health officials were not used to having to make rapid decisions, led to a degree of policy inertia, maybe even policy paralysis in decisions to close borders and institute harder lockdowns. And the resulting delays, for which there are obviously many reasons, were ultimately failures of judgment. So was the decision to continue to rely on hotel quarantine, after plenty of evidence of airborne spread and of leakage of infection into the community from at least 1 in every 65 to 200 infected people in quarantine. Wise epidemiologists help us to choose the best option each time. The second attribute is rich understanding. To Aristotle, living well requires a rich understanding of the nature of things and how they fit together as a whole. Wise professionals make good decisions in part because they understand the way in which the world works, including the nature of health and disease, the role of prevention and treatment, the contributions made by different types of health professionals and informal carers, the capabilities of local services, and the complexities of government and public health systems. A wise epidemiologist also understands what public health means for the community, including what they must go through with testing, lockdowns, mask wearing, isolation, disruption to ordinary life. That they are willing to endure such ordeals is only because they perceive the need to avoid something worse. Rich understanding also requires appreciation of the different roles, influence, and leverage that can be exerted. Understanding the way the world works well enough to navigate the best way of achieving this is the ultimate goal. And recognising that often the goal is the absence of something. The beautiful sound of silence is truth in public health. The third characteristic is few unjustified beliefs. Another way of thinking about being wise is it's the opposite of being foolish. And people are foolish when they believe or state things that aren't true, or do things that aren't warranted. In contrast, wise people can justify their beliefs through fact, experience, or reason. And it follows that unwise epidemiologists have unjustified beliefs, stemming from a poor knowledge base and misguided trust in unfounded approaches. They may also be unaware how well the outcomes of their work compare to others, or may be ambivalent towards doing what is best. On the other hand, wise epidemiologists have good knowledge of what works and what doesn't, and can justify their reasoning. They have few unjustified beliefs. Furthermore, they're also aware that everyone's expertise has its limits. Wise health professionals across the board know when they step outside the boundaries of personal competence and when it's best to consult a colleague. And the final aspect is a strong moral compass. Along with its practical application, Aristotle regarded wisdom as the ultimate expression of virtue or moral excellence. Virtue originates in our innermost thoughts and desires, and it determines what we value and the beliefs, ideas, and opinions that come to represent our personal ethic. Moral excellence and integrity, not just rigid beliefs, guide wise practitioners toward right and good actions. When we're making difficult and complex decisions, it's our community's best interests that usually represent moral true north. Wisdom requires not just having good values and ethics, but also living and modelling those values, which would perhaps better describe as walking the talk. Living our values can be very challenging when we're busy, when we're tired, when advice is not being taken by public leaders, or when we're facing public criticism. So how do you become wise? Well, completion of training, something you will have soon, signifies competence to practice, and throughout your careers, you'll be expected to continue to learn and to develop expertise. Yet wisdom isn't just layers of experience on a core of taught competencies, and nor is it attained solely by learning and following general rules. Rather, it's an emergent property of highly integrated brain functioning developed through upbringings and habit. Superior judgment requires deliberative, emotional, and social skills that are refined by problem solving many times over. We can accelerate this learning through combinations of simulation and reflective practice by going through many different types of scenarios. Rich understanding comes from thinking deeply, from curiosity, and from questioning. Our classrooms and workplaces should be places of inquiry and critique, where staff and students share ideas and challenge assumptions. Epidemiologists who have few unjustified beliefs habitually read, analyse, reflect, and welcome feedback, just as is the case for any other sort of health professional. They know the latest evidence in their field and what it means for their work, and they hold themselves to account by auditing their own performance, identifying gaps and opportunities for improvement. And values that underpin a strong moral compass are fostered through explicit commitment to community welfare. Aligned organisational values, consistent behaviour expectations, and good role models, like we have so many at ANU, can illuminate the path. Wisdom can't be learnt, nor does it come just with experience. It develops with time and it depends on choices and habits. The best in class are competent and professional, who make good decisions because they've enriched understanding of the nature of things, are motivated by what is true and right, and have heightened acumen through critical reflection and self-improvement. This combination of qualities, embodying professional attributes and individual ethos, I think personifies the wise epidemiologist. And I'm so proud that I see so many people with those attributes amongst our brilliant faculty at the Australian National University. Ripon, it's been a delight to be able to share these thoughts with you. I look forward to any further discussion about them in due course, and I hope the rest of the day goes really swimmingly for all of you.
Thank you, Russell, for your great speech, especially in this pandemic and what we should do the right thing. Yes, you echoed the best, like confident professionalism, and also the wisdom is the best way to go forward. Thank you so much for the nice talk. And in this stage, I would like to invite Lyndall for his speech. Please, Lyndall.
Thank you, Ripon. Thank you, Russell. I'm going to have keep it very short. So, but I first of all, again, like to thank and celebrate the traditional owners of the lands we're all meeting on, and pay my own respects to the Ngambri and Ngunnawal people for their custodianship of this beautiful country. I'd also like to acknowledge the incredible work of the organising committee. You have done an amazing job. So thank you so much, Ripon, Andini, Mary Lorraine, and Shinchen. So it has been really quite a challenge bringing this together in what, as you rightly title, a very non-normal world. So thank you. The school is very grateful. I'm also very grateful for all the people who are coming today and are listening to the students, because this is all about learning. And the conferences, it may feel like it's about presenting, but it's actually about learning. And that picks up on some of the words that Russell was talking about, that at the heart of wisdom is the ability to learn and learn from. So thank you very much for what you've pulled together in the program. I would particularly also like to acknowledge the depth and the breadth of the work that is being presented today. It's right that you create a title about bringing health into research into the new normal. I guess the question is, what will the new normal be? What I see right now is that the new normal is looking decidedly like the old normal at the moment. In fact, this pandemic, in many respects, even though there was a brief moment when health became the most important preoccupation of the whole country, indeed the whole world, you can see it slipping back. In this brief period, perhaps a year, health was driving our social policy, our economic policy, even our border policy. And the question is, how can we position health to have that resonance and visibility in the future and take its rightful place as one of the most fundamentally important elements of a good society? But it has, you can see the cracks where we have job seekers and job keepers, but we had no package for homeschoolers. And those cracks start to show up the inequalities that the pandemic brought with us. Job losses were greatest amongst the poorest, and that's continuing. Women in particular, careers have been king hit by this pandemic, and that's continuing. And the lowest vaccination rates in our country, and indeed the world, are in lockstep with marginalisation and disadvantage, both in terms of social groups and in terms of nations. So the new normal is showing us a lot, telling us a lot about the old normal. And our work, I think, is important to start to challenge that and seek to address it. And I see that in the offerings and the work of the student body today. And for that, I'm incredibly excited. So what I'm seeing is there is a span of work in the student community in the school that understands that health is not just a physical disease, it's also a mental disease, and it's also a social disease. And we're seeing work that talks about vaccination rates. We're seeing work that talk about tuberculosis, and we're seeing work that talks about discrimination. We're seeing people talk about the lived experience of trying to manage work and family. We're seeing presentations on national issues and global issues, all from one student body. It's an extraordinary depth and breadth, and it speaks to what I believe health needs, which is deep knowledge, and multiple viewpoints to bring to bear on understanding how to make it better. This conference holds all that in the student work that you're presenting today. And it's very exciting to me to see this span of work that represents, in my view, the true depth and heart of population health thinking and contribution. So I would like to thank all the students for bringing their work together today, impressing me already with what they're doing. I'm very excited to hear what they're learning and learn from them. And I again want to thank very much you, Ripon, and the whole committee for making this possible. Thank you.
Thank you, Lyndall. We are so happy that you inspired all of us for going forward in all the stages. And thank you so much for your speech. Yes, as an epidemiologist, health is not confined to bodily things. It is beyond body. It's multi-dynamic view, as you said. Thank you so much for your speech. And in this stage, I would like to invite our first presenter, Alison Wright, who will present a place-based analysis of experiences of everyday discrimination in Central Australia. That is, Lyndall was saying, it is beyond health. So please, Alison, you can start.
Thanks, Ripon, and thanks to the committee. I'll just make sure my screen is up there. Is it up there?
Yeah.
Great, thank you. So to begin with, I'd like to acknowledge the traditional owners of the land on which we're all meeting today. I'm very proud to be presenting this from Aranda country here in Mabachua, Alice Springs. I'd also like to acknowledge my collaborators and the MyQI study. So to begin with, the first picture on this slide is of a website that names the most racist towns in Australia. Alice Springs is named #1, with the underlying headline that hardly a week goes by when we don't see a story about discrimination and racism in this context. And an example is shown beside there of a racially segregating hotel guests in a hotel in Alice Springs. That story made BBC headlines as well. So there's consistent and growing evidence that discrimination impacts on health and well-being. We see that in Australia, but we also see it in First Nation contexts globally. Racism has been described as the root cause of the other social determinants of health and has led to the Centre for Disease Prevention and Control naming it as a serious public health threat just earlier this year. Our current evidence from the MyQI study across Australia says that the discrimination prevalence is high and is highest in remote areas. My analysis today shows you that a place-based analysis can help us to understand what that means for community and may be able to help with community decision-making around this issue. So let me bring you into the context. Central Australia, we define Central Australia broadly, colloquially, it's considered the southern part of the NT, but there are nations that cross borders. So we've got a broader definition. Within that context, there are 2 towns, Alice Springs and Tennant Creek. There are also a series of small remote communities ranging from population of 10 to about 900. And this photo is an example of one. It's Lajamano. It's up in the left-hand corner. It sits on that Northern Territory border, Warlpiri community. We also have these towns, Alice Springs and Tennant Creek, and within the towns we have town camps. So this photo here is of Ilpi Town Camp. It borders the suburb of Satadine in Alice Springs here. You can see it's on the fringe, and many of our town camps, there's 17 in Alice Springs, sit on the fringe of the community. My approach is to use a mixed methods, and I worked very closely with an Aboriginal organisation here called Tungunjira Council. We firstly asked people in 2 workshops about their experience with discrimination and racism in Central Australia. And then we grounded this with qualitative analysis. We analysed data from the MyQI study of 615 participants in Central Australia. The measure of everyday discrimination used in the MyQI study is an 8-item measure. It has a collection of scenarios, and people are asked to rate not at all, a little bit, a fair bit, a lot in response to those measures. We then combine those measures to get an overall total score of discrimination. So firstly, we talked to people about what they thought Central Australia was like, and these are some of the key things. Some of the things that I'll draw your attention to is being in town makes it worse, feelings that discrimination is higher when you're in town compared to the community where you might have the majority Aboriginal people and non-Aboriginal people are working together in those settings. Different individual and family responses, that mainstream services are sometimes hard to deal with. They look at us differently. There's a bad service or no service at all. Often getting people through the door of those services is tricky. It's one of the reasons Tungunjira established a one-stop shop to provide services for their people. Obviously, lots of discussion in this setting around the policy and the structural racism. Many of you will be aware that in 2007, the Commonwealth Government intervened in what is known as the Northern Territory Emergency Response. And at that time, the Racial Discrimination Act was stopped and to allow a passage of measures into this setting. So the questions that we derived after talking to people that could be explored with MyQI data is, do the experiences of everyday discrimination vary according to where people live? And what role does community cohesion have on the experiences of discrimination? As I said, it's an 8-item measure that looks at specific scenarios. These are the scenarios on here, and the faces give you an example. So I'll just go through a few of those. I'm treated with less respect than other people. 50% of the sample in Central Australia responded to that one. People act like I'm not smart, 40%. When we total those, we found that 70% of the sample experienced any form of discrimination. And that when we looked at this by remote community, town, camp and suburb, as I highlighted previously to you, that it's more likely to be a higher prevalence of any discrimination in town camp setting, in town settings. These results remain consistent after adjusting for socioeconomic characteristics, so things like family financial status, whether people are on Centrelink or welfare benefits, whether they had a basics card. We still saw those same results. Our next question asked, does community cohesion play a role? Overall, we can see that the prevalence of discrimination drops in all participants when we consider community cohesion. When we stratified that by the type of the settlement type, and I'll proceed with caution, as Russell mentioned in his speech here. Some of these cell sizes are very small when we break it up by this, but we can see that a similar phenomenon happens in remote communities and in town camps, but we're less likely to see that in the suburbs. And part of that has to do with what people were saying, that where we've got decision-making structures in those communities. We know our elders, we trust and respect them, and they support us. In this setting, Aboriginal people make up 45% of the population, but this varies, and race relations are a matter of everyday experience. They're compounded by a public deficit discourse that negatively portrays Aboriginal people and their families. The high prevalence of everyday discrimination that we found in the MyQI triangulates with people's sentiments that racism is in your face. A place-based analysis really helps us to understand those differences. And we've shown that discrimination is highest in towns compared to remote communities. We suspect the high community cohesion is associated with a lower prevalence of discrimination, and that this may also vary by settlement type. Overall, to improve health and social outcomes, we must acknowledge the high prevalence of discrimination. There's still a kind of sense in this place that it's a very little acknowledgement of it. Act to confront the dominant and colonial prejudices and enhance community cohesion in these places. And I'll leave the final word to my colleague who I spend every day working with, a town camper who grew up both in Yundamu and Thakapurta community. Tanganjira is an Aranda word which means working together. To do this, we need to be heard and respected. This research is important evidence. Discrimination is something my family and community feel in all aspects of our lives, and it is hurting us. We are strong people, but we are weakened. Thank you. Thanks very much. Sorry.
Hi, Alison. We're so sorry. But yeah, that's the story that we were trying to listen from our community, our family, RSPH family and on. So yeah, now we'd like to have questions from audience to Alison.
Sorry, I don't mean to put people off asking questions. I'm very fine to answer questions.
Yeah, Alison.
We have one question from Lyndall Ripon.
Yep, Alison.
Yes.
Yeah, Lyndall, please.
First of all, Alison, you should not apologise whatsoever, because what you're talking about is the harm the discrimination does, and it's felt, and it's real, and it's embodied. And so I want to thank you actually for making that so visible. And that's part of our work, is to see the way this gets into people's bodies and minds and changes their health and well-being. So thank you very much for your work. One of the things that I really thought about was this concept of social weathering, which I find a particularly powerful concept of understanding how racism, sexism, and indeed all forms of discrimination starts to alter people's minds and bodies. And I wonder if you've come across that concept. I think it's quite an elegant and beautiful concept. It picks up a whole lot of nuances around the everyday experience of being treated as less. So Gilbert Gee is one of the thinkers in that area, but there's quite a strong, I know Ray is aware of Gilbert's work, but I think that might be a nice, helpful concept to play with in explaining the health harms that you're investigating.
Thanks, Lyndall. No, I definitely haven't, but it's an area that I'll have a closer look at. Yeah, it's certainly, you can sense it in the everyday, but you can also feel it in the, in your overall discussions with people out here.
Yeah, thank you, Lyndall. Please, Joanna, you have a question. Hello, Joanne.
Oh no, sorry, I just made a mistake in raising my hand. But Alison, thank you for your talk. It was really good. And sometimes it's important to show some emotions as well, which people try to hide. So yes, don't feel sorry about that. Thank you very much.
Thanks, Joanne. I mean, I practiced this yesterday and I didn't get emotional. So I don't know, maybe my kids set me off this morning.
Thank you, Alison. Actually, for this time, overall, how you can relate to this present new normal situations with the study in NT, from where you are just doing your research and your findings. I mean, how you can link with the present situations. Though it is not your part of, though it is not part of your research, but just for curiosity, can you just link the situation of in your study area about the present situations in Australia?
Yeah, sure. Yeah. I mean, it's a really interesting time here in Central Australia. And I feel very lucky and I'm very apologetic for all of you in lockdown. We're definitely not in lockdown here. And we've only had, some minor hiccups throughout the experience of the COVID pandemic. Part of that is because we have such a strong Aboriginal community controlled sector here in the NT. Very cautious sector as well. They went hard and they went hard very early and probably was heavily influential in national settings around locking borders and restricting movement into remote Aboriginal communities. What we're struggling with, and it's an inequity that's faced everywhere, is getting the vaccination rates up at the moment. So some of our community controlled sector have been working hard on increasing vaccination rates, but it's a pretty tough slog in this environment. So even in our town camps where people can easily access the vaccine, in some of our town camps, we're sitting at around 20% vaccinated, but others, we've got 90% vaccinated. And that's the same for our remote settings as well. Some communities are 90% and others are sitting around, 10, 20% of the population. So it's an interesting time, but it's certainly a time where key cultural factors have been celebrated. The strength of the community controlled sector, and also that we saw it really early on, messaging around going back to country. So the strength of being on country at this time.
Yeah, thank you, Alison, for your insight and linking with the present situations. Now in this stage, I would like to invite Sarah Patel for her presentations. She will present on measuring the performance of immunization system. She will do that from the perspective of literature review.
Thanks, Ripon. Can you see my screen?
Yes, please.
Okay, great. So hi, everyone. I am Sarah. I'm in my first year of my PhD. And I'm going to be telling you about one of the literature reviews that I've done as part of my PhD, which is measuring the performance of immunization systems. So I'd like to start by acknowledging the traditional owners of the lands where we're all individually located, and particularly acknowledge the traditional custodians of the lands that I'm speaking from, the Wangal clan of the Eora Nation. I pay my respects to their elders past, present and emerging, and extend this respect to all First Nations people joining us today. So I'll start with a little bit of a background about how this literature review fits into my PhD, and then tell you about the methods for my literature review, and then briefly some results and the conclusions and next steps for my PhD. So my research is interested in looking at whether vaccination rollouts in the context of infectious disease emergencies strengthens routine immunization systems. In the past, public health crises have prompted strong responses and a lot of investment for mass immunization programs. But often what happens is that these systems and processes that are put into place to deliver those programs fall away after the program concludes. So that ends up being limited long-term benefits, partly because, well, in large part because the financial investment to maintain those processes and systems, it stops being available. And so those benefits can't be sustained. There's mixed evidence from some of the findings from notable immunization campaigns such as polio eradication and measles and rubella elimination, with some evidence pointing to wider health systems benefits. But there's also documentation of the negative impacts of these campaigns, especially in countries where health systems are weak and where these programs are probably more likely to be implemented. The clear benefit of these initiatives on strengthening routine immunization systems is lacking. A lot of the evidence comes from qualitative research through interviews with immunization program managers and country representatives, but there's limited quantitative evidence of and objective measures of benefit, especially sustained over time. So COVID vaccination programs are a significant opportunity for us to strengthen immunization systems. These programs for COVID have been implemented with speed and scale. And that means there's been a lot of investment in building up workforce, supply chain capacities, and other elements of the immunization systems, just because they've had to be scaled up so quickly. COVID vaccination is also unique in that it's targeting adult populations, whereas most routine programs, especially in low and middle income countries, are targeting children. So we've had to find new ways to reach the population. So there's been substantial investment in COVID vaccination programs, particularly efforts to build up workforce capacity, strengthen supply chains, and to digitize information systems. Pacific Island countries have largely been spared the high burden of disease of COVID observed around the world. Many countries still have 0 cases, and only a few of them have, and some of them just have a handful of imported cases. There's been a few countries with large outbreaks, but those have been more the exception than the rule. So I guess the question is then, how do you measure the impact of COVID vaccination programs in countries like that, where there hasn't been a lot of disease, and so you can't really measure it, their success by their impact on disease? And so that's where my PhD is sort of coming in. So my PhD is looking to understand whether the implementation of COVID vaccination programs has strengthened routine immunization system in Pacific Island countries. Part of this is looking at how immunization programs are measured, and especially how strengthening of immunization programs is measured, because this hasn't routinely been done in the past, or is usually a secondary consideration rather than a focus. So strengthening strengthening immunization systems is a focus of the Immunization Agenda 2030, which is the global vision for immunization programs for the next decade. And this is going to drive a lot of what immunization programs around the world are going to look like, especially in low and middle income countries. So the IA 2030 comes with a comprehensive implementation plan and a monitoring evaluation framework. So the frameworks like these are important for measuring both the evaluating program outcomes and accountability to achieve goals, but also to have data to inform decision making and to drive what the programs look like. So what my study is trying to do is understand how the performance of immunization systems has been measured, and this can provide a base then for me to look at how immunization systems have been strengthened in the Pacific Islands and whether COVID vaccination has had an impact on immunization systems over there. I also would like to have indicators that can be used in the future to inform vaccination campaigns in the context of other infectious disease outbreaks. I didn't do a formal systematic review for this study because I wanted to be pragmatic, and knowing that a lot of these tools are actually published in the grey literature, specifically by peak organizations like the WHO and Gavi. So I decided not to do a systematic review, but use systematic methods in my literature review. So I searched the peer review literature through Medline, as well as the grey literature, and went through the websites of peak organizations like WHO, USAID, Gavi, etc. And then once I had a list of tools, I sought advice from global experts in immunization research to make sure that that was a comprehensive list. I included tools that incorporated indicators on at least one component of the immunization system, and if they were published in 2000 or later. So I extracted data on the indicators into an Excel sheet and mapped them against the elements of the immunization system. And there were 8 of these. So there were information systems, which is about all the data that's collected on immunization programs, whether that's through electronic systems or paper and pen. Workforce, so the immunizing workforce. Service delivery, which is actual delivery of the vaccines to people. Vaccines and supplies, and that includes things like supply chains, vaccine management and cold chain capacity. Governance of the program and financing of programs. Regulation, which incorporates pharmacovigilance. And demand generation, which is more than just addressing vaccine confidence and hesitancy issues. It's really about building demand for vaccines and having engagement with communities to build that demand. Once I had these indicators, I identified common indicators across the tools and tried to identify trends across the tools. So I found 17 tools. Most of them, 14 of them were in the grey literature and 3 were in the peer reviewed. And of the ones in the grey literature, most of them had been published by the WHO. So just given the time constraints, I won't go through all of the findings for each of the different immunization systems elements, but what I will do is focus on the ones that I'm interested in for my PhD. And that's vaccine coverage, which is the outcomes of immunization programs, and then information systems and workforce. For the coverage domain, the tools measured coverage of specific vaccines, the most common of which was the 3rd dose of DTP and the 1st dose of measles vaccines, as indicators of the strength of immunization programs. There were also indicators for coverage dropout and coverage by demographic factors and geographical areas, most commonly districts, to measure the reach and equity of coverage, and basically how well immunization program functions, as opposed to just having high coverage of a single dose of a vaccine because of supplementary immunization activities. 0 dose coverage, over here down in infrequent indicators, is a relatively new concept that's come up in the IA 2030, and that's probably going to be a direction that the world is going to be moving towards measuring. And it basically is trying to find those populations who haven't received a single dose of any vaccine, because these clearly are the populations that are being excluded from the health system overall. So it's particularly important to try to find these populations and increase coverage. New vaccine introduction was measured by a few tools, mostly looking at whether new vaccine has been introduced in a given time frame or whether new vaccine use has been sustained over time. Under information systems, most tools looked at indicators for quality of reporting, so things like timeliness of reporting, completeness, and the quality of data, so accuracy and consistency of data across different information systems. Some also asked whether there were certain systems in place, things like electronic immunization registers, for electronic stock management systems. Less frequently, there were only 2 tools that included measures of data use in decision-making and to inform program planning. Under workforce, supervisory visits was the most commonly measured item. So that was really about the frequency of supervisory visits or whether a visit had occurred in the last month or quarter. Health worker knowledge and receipt of training were measured less often. And only the IA 2030 included a measure for health worker density. None of them included any measures for public health workforce. So just to wrap up, over the different tools over time, you could see that there's been this shift from focusing on the outcomes of vertical programs to universal health coverage. And so that's really a shift that's happened in global priorities and is changing the immunization landscape. There's been that shift from measuring coverage of individual vaccines to increasing coverage of all vaccines and other healthcare as well. Indicators in information technology and integration with other services are also increasing. There's some indicators for some domains that are still evolving, particularly workforce training and capacity, and the availability of public health workforce. We don't really have any for those right now. And I didn't get a chance to talk about this, but indicators for demand generation are also evolving and looking at ways, things like, are there digital listening systems and things like that, rather than just examining whether there's been a community visit. So the next steps for my PhD are to critically appraise the indicator tools. And this is just to help with comparing across different tools. And if anybody has any ideas on this, I would really welcome them. And then I'm going to identify a list of indicators that's suitable for the Pacific Islands, so taking into account context and whether the data can be collected there. And then I plan to take that list and do a stakeholder consultation to finalize a list of indicators to measure the impact of COVID vaccination introduction. Yep, I'd just like to acknowledge my supervisors and the funding I'm receiving from my scholarship. Thank you.
Thank you, Sarah, for your presentations. I would like to allow Gijem for your question, please.
Yeah, sure. Thank you, Irfan. Awesome presentation, Sarah. I was just curious about, you were saying it's really valid that like a lot of these settings haven't had any adult vaccinations before. I was wondering if you've seen any settings where now that they've started to roll out COVID vaccines to adults, whether they've then gone on to roll out other things that they haven't previously had the capacity to do before, like flu or something like that?
So I think that's probably going to be something that my PhD will look at. We haven't seen that so far because everybody is still so focused on COVID vaccines. And some of them are still, like we've seen pretty high coverage in countries like Fiji, I think Samoa as well, but there's still some countries where coverage is quite low. So everybody is still really focused on getting out COVID vaccines. So it'll be interesting actually to see if, you know, a couple of years from now, whether the new processes and things like about governments, you know, to introduce new vaccines has resulted in increased capacity to do those kinds of things rather than depending on the WHO and other countries and see if they have yet introduced things like flu vaccine. I know that lots of countries are looking at introducing pneumococcal vaccine as well. So things like that. There's also the issue of Gavi funding, which is probably going to be running out for some countries that are currently covered in the Pacific Islands. So it'll be interesting to see whether there's been any benefits from COVID vaccine in building capacity to be able to do those things later on.
Yeah, thank you, Sarah, for your nice presentations and the Q&A sessions. So yeah, in this stage, I would like to invite Brownie Wicks for your presentation, please. Yeah, you are on.
Great, thanks very much, Ripon. It's a real honour to be part of this conference, so thanks very much for having me. I'm calling in from Ngunnawal Ngambri country, and I'd like to acknowledge that I'm a visitor to this place. I grew up on Darug and Gundungurra country west of Sydney, but I've lived on Ngunnawal Ngambri country for over 20 years. So I'd like to offer my gratitude and my respect to Ngunnawal and Ngambri elders for their care of country since time immemorial, to the ancestors for keeping me safe while I've been on country, and also to country itself for providing everything I need for a healthy life. I'd also like to offer my respects to First Nations brothers and sisters who are in the audience today. Yuma, everyone. So today I'd like to tell you a little bit about my PhD research, which I'm lucky enough to have been doing with this stellar panel of supervisors that you can see on screen. Rob Dybel from over at the Fenner School, Beck Colvin from the Crawford School, and your very own Ginny Sargent from here at the Pop Health Exchange. So I'd like to acknowledge their exceptional care and guidance throughout this project. And also to say that any errors or shortcomings in this presentation are entirely my own and not at all theirs. So my project looks at food systems, and I'm sure I don't need to convince you that food systems influence human health in multiple ways, both biophysically and socioculturally, and from various perspectives or roles within the food system. So not just nutritional outcomes for consumers, but also working conditions and livelihoods for farmers and food system workers, as well as impacts of food system activities on the environments in which we live. So things like environmental contamination, greenhouse gas emissions, and impacts on biodiversity, just to name a few. And food systems also impact sociocultural aspects of health and well-being, enabling or constraining different forms of cultural expression or social connection, among other things. But on aggregate, our food system is failing to support our health adequately. And on a global level, we're producing vast quantities of food. This is coming at a significant environmental cost. And the image here on screen represents agriculture's contribution to exceeding the safe operating space of a number of planetary boundaries, particularly nutrient cycles of phosphorus and nitrogen, as well as biodiversity, among others. And unfortunately, much of this environmental impact is borne in vain because we waste substantial proportions of the food that we produce. And the food that does happen to make it into human bodies doesn't nourish them equitably. We've got vast numbers of people suffering from some form of malnutrition. And then from a production perspective, the situation isn't that peachy either. Farmers and food system workers are exposed to high levels of occupational hazards, precarious work, often low incomes. And in a number of countries, farmer suicide rates are much higher than the general population. So while this is just a handful of global aggregate indicators, and without any nuance around how this is shared across countries or within countries or by gender, for example, I think it does paint a picture of a food system that's a few sandwiches short of a picnic, so to speak. And I'm interested in how we might transition towards food systems that are healthier, fairer, and ecologically sustainable. Or to use a word from human ecology, which is the program I sit in, more biosensitive. So this is about being in tune with, sensitive to, and respectful of the life processes that underpin our existence. And this is a conceptual framework of Professor Stephen Boyden of a biosensitive society. And that's one that recognises that the things we do as a society have both a direct effect on our health as well as an indirect or delayed effect that's mediated by the impacts of the things that we do have on the ecosystems in which we live. And that a biosensitive society would pay attention and respond to both. So going back to those food system problems, a human ecological approach is interested in finding solutions that take account of both of these pathways and that promote human and environmental well-being simultaneously. So it was thinking about these issues and these concepts that led me to to community-supported agriculture, or CSA. And CSA is a form of solidarity economy in which a group of consumers pledge upfront support for a farm in return for a share of the harvest. This could be a weekly box of vegetables or a monthly supply of meat. But rather than paying for a fixed amount or type of produce, consumers are paying for a share of the harvest. And this is usually from a small scale organic or regenerative farm. So what characterises CSA is this direct relationship between a farmer and a consumer who agree to share the risks and rewards of farming over an extended period. So hopefully you can see how this structure of CSA is such that it exposes consumers to those life processes, both the ecosystems and the farmers' life processes, who are producing their food, much more so than shopping at a supermarket would, for example. So I was really interested in finding out what is happening in Australian CSAs, and in particular, why do people participate, and what, if anything, changes as a result. Now, I had hoped to be able to interview both farmers and consumers face-to-face at various case study sites around Australia. However, COVID had other plans, so meant that was not possible. What I ended up doing was a series of online interviews, both farmers and consumers, or members as they're called in CSA. And I supplemented that with a smaller number of Zoom interviews that just focused on members. I looked at traditional CSA, which is a single farm, as well as a local multi-farm produce box subscription scheme that's run by Southern Harvest Association here in the ACT, which is based on CSA principles. In the consumer surveys, I asked a mix of qualitative, open-ended questions, such as why they started participating and whether their reasons had changed over time. And also some Likert-style questions about changes in vegetable consumption and what influences them when they're procuring food. Also some various other things, including some validated scales from social psychology about values. Now, I don't have time to give you a comprehensive picture, but I thought you might be interested in just a taste of some of the preliminary results. These are responses from CSA members who belong to a vegetable CSA, so not the meat CSA, in terms of how often they would consume at least 3 different vegetables with their main meal. So there's the before CSA in the dark green-blue, and then since CSA in the lighter green-teal colour. And I think you can readily see that there's a shift towards always having at least 3 types of vegetables with their main meal. And this was also borne out in the qualitative responses, where many people spoke about eating more vegetables and a greater variety of vegetables, often because they enjoyed the flavour more. Many people remarked on how different CSA vegetables taste to supermarket vegetables. Other people spoke about valuing food more, and this was for various reasons, including knowing where it had come from, knowing how it had been produced, knowing their farmer, but also knowing that their farmer had grown it specifically for them. And for some people, this translated to a heightened imperative to avoid wasting food, and often to increased creativity with cooking or with their conceptions of what a meal should be or should look like. Something I was surprised about was many people spoke about enjoying salad and leafy greens more. And for some people, there was quite a visceral degree of excitement about vegetables, which is pretty uncommon. And like you can see on the screen here, someone saying that they crave fresh vegetables and they get giddy with excitement when their veggies arrive. For other people, the change was a bit more subtle, such as this person who used to hate salad, but now they only strongly dislike it. And of course, there were others who experienced a no change at all in their food preferences or in their vegetable consumption. But moving beyond the food itself, there were other things that featured among respondents, reasons for doing CSA and the benefits, including environmental reasons, supporting regenerative agriculture, animal ethics, aligning their practices with their values, which was also a source of increased well-being. And a big one was the connection with their farmer. And that sense of connection also featured strongly in the farmer survey too. So relationships, connections with members were some of the key benefits of CSA for farmers, in addition to improved financial situation and improved quality of life. But in some cases that connectedness made the difference between being able to keep farming or not. So that's just a very small taste of some of the results that are emerging. If anyone is interested in hearing more, please feel free to get in touch. I'd be happy to chat. I could bore for Australia on this stuff. A very big thank you to my research participants, to my supervisors and my extended brains trust of mentors and colleagues, as well as the Australian government for the scholarship that's kept a roof over my head while doing this project. And finally, a big thank you to the organisers of this conference. Thank you very much for the work that's gone into hosting this. It's an honour to be part of it and to see all the really interesting work that's going on over the research school. So thanks very much for listening and sending heart-shaped pumpkin vibes out to all of you.
Hi, Brownie. Thank you so much for your nice presentations. So yeah, now I'd like to receive questions for Brownie.
We have a question from Rose Ripon.
Yeah. Hi, Brownie. Rose, please.
Thank you. Thanks, Bronwyn. That was a really interesting presentation. I haven't heard of CSA before, and so I'm interested in looking it up now. I just had a question. How is the relationship between the consumer and producer, or the farmer and the member, mediated, or what's the platform there when you cut out the sort of supermarket middlemen?
Yeah, so people often just pick up directly from the farm, or sometimes some of the farmers deliver either to homes. Often there is a hub, like a central hub somewhere in the city, but with CSA, there's usually a direct interaction between the farmer and the consumer.
Okay, thank you. Do you think that then would limit or mediate how it could be scaled up?
And something that I didn't have time to talk about, I'm just conscious of using up other people's time, but the Southern Harvest multi-farm produce box scheme is mediated by a not-for-profit organisation, and it has multiple farms contributing and has different ways of different distribution points actually around Canberra. So I'd be happy to talk to you more about that offline. Yeah.
Thanks so much, Bronwyn.
Yeah, thank you. Hello, Lyndall, please.
So that was absolutely a brilliant presentation. Thank you so much, Bronwyn. I'm kind of really, I guess, Rose has sort of asked the question I was interested in, which is how does that relationship get built, particularly when you have to deal with distance? And that's a scale question as much as anything. But it sounds to me like that. Is that something you'll talk about or think about in your PhD, do you think?
Yes, and I think that's something that, because I've got the two slightly different models, so the kind of pure CSA, where there is this direct relationship. I did look at postcodes, and particularly how far these things travel. There are some that are urban. There's a farm called Spoke and Spade in Melbourne that uses urban front garden plots and delivers by bicycle within a 10-kilometre radius. But then there are farms on the outskirts, so of Melbourne, sort of in Daylesford, Hepburn area, that have that feed consumers in their local area as well as in the metropolitan area. So you've got kind of 150 kilometres going away. Often lots of communication via social media and regular emails, as well as that in-person week-to-week interaction during collection.
Yep. Thank you, Brandon. I think many of us would like to connect with you for knowing more about your research. So in this stage, I would like to invite Fasil Wagnil for your presentation, please. Fasil, go on, please. Fasil, maybe you are mute.
Hello, can you hear me?
Yeah, please. And you can.
Thank you, Ripon, for giving me a chance to present our finding. The time is now midnight in Ethiopia. This may affect my sound. Sorry for that.
No, you can on your video if not any problem. Yeah,
it's midnight.
Thank you.
It's midnight. It's midnight in Ethiopia. Sorry for that. The title is Effects of Zinc and Vitamin A Supplementation on Tuberculosis Treatment Outcome and its Prognostic Markers. And this is a systematic review and meta-analysis. My supervisors, Professor Darren, Kerry, and Dr. Campylobacter. It's not working, sorry. Yeah. As introduction, tuberculosis remains a major global public health threat, with WHO 2020 report that it's around 10 million new cases and 1.4 million deaths each year. And as we know, the tuberculosis and malnutrition has a bidirectional relationship with each other. So undernutrition is a major risk factor for tuberculosis, which is potentially responsible for 2.2 million cases of TB per year globally, and even more than HIV. Particularly from the malnutrition, micronutrient deficiencies such as vitamin A and zinc deficiencies are common among TB patients. However, these micronutrients has a pivotal role in the immune systems by increasing the growth and function of T and B cells, antibody production, and to maintain the muscular epithelials. So this activity may help us to the bacterial clearance and rapid recovery time. When you see in the previous evidence, in some trials, micronutrients has a positive impact on the sputum smear conversion as well as reducing mortality. However, the recent earlier trials show that as a contradictory, that is non-therapeutic effects. So our research question is just this specific vitamin A and zinc supplementations on the treatment outcome as well as the prognostic factor remains inconclusive, inconsistent, and under-investigated. So the study objective is that we try to summarize the available evidence to determine the association between vitamin A only or zinc only or both combination supplementation on the TB treatment outcomes or the prognostic markers such as sputum conversion, the serum zinc levels, retinol, and hemoglobin levels. So when you see on the method section, this is a systematic review and meta-analysis, and we tried to follow the PRISMA checklist as well as reported using the Cochrane handbook. And this protocol already has been registered in the Prospero. So in this, the study selection and eligibility tried to follow the PICOT criteria. Adults TB patients considered as a population, zinc and vitamin A supplementation as an intervention as compared to the placebo group, and the outcome was the primary outcome is successful TB treatment outcome, and the secondary outcome was the prognostic markers. So in order to determine this outcome, we included only randomized clinical trial studies. Let us move on the search strategies and data extraction and biases. We searched in different databases like PubMed, Embase, Scopus, and some websites like ClinicalTrial.gov and reference lists, as well as we tried to find the gray literature or unpublished articles from Google and Google Scholar. Two authors independently extract the essential information blindly, and then we tried to apply the Cochrane risk of bias assessment tools, which has around 6 components. And then finally, in order to assess the grading of evidence, we utilized the GradePro software. In the data analysis, data were imported to the Riemann version 5 software for analysis. And in the statistics, risk ratio as well as mean difference for dichotomized and continuous outcome correspondingly. Whereas a random effect model was used where appropriate, especially in the high heterogeneity, we used the meta-analysis with random effect model. And in order to check the publication bias, we used funnel plot with eager test. And the statistical softwares, especially the I-square statistics. So in the statistics, heterogeneity across studies was examined. So when you see on the results and discussion, as you see on the flow diagrams, first we identified 2,195 publications, and then by different criteria, 9 studies comprising a total of 1,375 participants meets the eligibility criteria at the end. When you see on the first objective, the effects of vitamin A and zinc supplementation on TB treatment success, which shows that this intervention was not significantly associated with TB treatment success, or even the vitamin A and zinc supplementation, as well as zinc only and vitamin A only. So in the 3 interventions was not associated with the TB treatment success. This finding is already in accordance with another previous meta-analysis that showed an insignificant effect of micronutrient supplementation. So for this non-significant effect may different factors such as the insufficient numbers of included studies, for example, in our analysis, and the participant of nutritional status and biochemical profiles was not characterized. And even we couldn't sort or we couldn't do a subgroup analysis based on the comorbidities, such as HIV/AIDS or diabetic mellitus. So these factors may contributing for an insignificant effect. And the other result or other objective is that the full effects of the combination of zinc and vitamin A supplementation was interestingly associated with sputum smear conversion at the end of 2 months. However, this effects, this zinc supplementation only was not associated with the early sputum smear conversion. When you see on the effects of this vitamin A and zinc supplementation on the serum retinol level showed that it has a positive effect, especially at 2 months as well as at 6 months. This may be due to the oxidative conversion of retinol to the retinal needs that zinc-dependent retinol dehydrogenase enzymes. So in order to elevating the serum retinol values, the combination of zinc and vitamin A is essential based on our finding. The other objective, just in order to determine the full effects of this combination supplementation on the hemoglobin level, shows that this supplementation was significantly associated with elevation of hemoglobin levels at 6 months follow-up. This could be due to various mechanisms. For example, zinc increases the lifespan of red blood cells, as well as the zinc-dependent enzymes are involved with the hemoglobin synthesis. In addition to this, similarly, vitamin A appears to mobilize iron store, enhancement of the hemostasis, and even in order to prevent anemia related to infections. So by these activities, the hemoglobin level may be elevated from the intervention group. Here it is a summary of risk of biases, and this figure shows that the trial is adequately the low risk of random sequence generation for all included studies. However, 5 trials were judged to be a high risk of attrition bias. That means incomplete outcome data were recorded around 5 articles from 5 trials. So in overall, we have introduced some strengths and limitations. When you see on the strengths, the included studies has a low risk of bias. And the most important thing is the dose of micronutrients for TB patients are still not standardized. However, we attempted to examine a specific micronutrient intervention, particularly the combination of vitamin A and zinc deficiency, that's rather than the multi-micronutrient supplementation haphazardly. But we acknowledge some limitations in our study. For example, the inclusion of the study published only in English, which may compromise the generalizability, and the stratified analysis was not carried out because of we include small trials. And lastly, this included studies didn't describe other sources of vitamin and zinc supplementation like diet sources in the study participants. Especially these characteristics were not recorded in the primary studies. Therefore, overall, as a conclusion, our study found that the effects of this dual supplementation in TB patients was not significant, although it improved the sputum smear conversion, the serum zinc level, the serum retinol level, as well as the hemoglobin levels at a different duration of follow-ups. So we recommended further trials to determine whether zinc with vitamin A supplementation is needed to improve, particularly for TB treatment outcomes in adult TB patients. Here it is our sampled references, and finally, I would like to thank the RSPH Student Conference organizer, my supervisors, and Debre Marcos University Digital Library. Thank you for watching. This is what I have.
Thank you, Fasil, for your nice presentations. And I must thank you for joining from Ethiopia at night with maybe low internet connectivity. Yeah. So I really thank you so much for joining with us. So I think no questions for these sessions. And I would like to tell my audience that please contact with Fasil for any other query regarding his presentations. So thank you, Fasil. And now in these sessions, I would like to invite Daniela for her presentations. And this is the last presentations of our first session.
Cool, let me just get started with the presentation, bear with me.
Yeah, you are on, Daniela.
Perfect. And let me just share my screen now. Excellent. Hopefully you can all see my screen. Yes. Perfect. Excellent. So thanks for that, Ripon. So my name is Daniela, and I'm a PhD student at the Center for Research on Aging, Health, and Wellbeing. And today I'm talking to you from Ngunnawal, Gambia country. And I would like to pay my respects to elders past, present, and emerging. And I would like to extend that respect to Aboriginal and Torres Strait Islander peoples here today. So today my talk is about one of the chapters in my thesis talking about brain and behavior. And you can see here, hopefully, if this decides to move, perfect, what I'll be talking about for the next 10 minutes or so. And in regards to background, what I really would like to bring your attention is just to the rationale and motivation for these types of studies. So when we're talking about behavior, we're trying to understand past, current, and future actions that could give us a better idea of predicting physical and mental health outcomes in the future. So for instance, if we have someone that continuously eats fatty foods, they're more likely to develop high cholesterol, and then that could create a host of cardiometabolic issues later down the track. But there's another way to go about understanding behavior, and that's going the way of personality research, which quite simplistically, personality could be defined as consistent patterns of behaviors that then can be classified into personality types or personality traits. These are some of the two most popular personality theories, but particularly the big five in recent years, because it's quite relevant for work environments, and it involves traits such as openness, conscientiousness, extroversion, agreeableness, and neuroticism. And when you have an idea of individual differences to these particular traits, you can also make associations with outcomes. So for instance, people that have high levels of neuroticism are more likely to experience symptoms of anxiety and depression that could translate later into depression and anxiety disorders. Now, something in here that it is quite important to understand is that this type of research is quite top level. So it's what we can observe, and it leaves something quite essential in the background, which is the brain, which is the organ that actually regulates all our behavior. And this is where the theory that I'm researching as part of my PhD comes into place, which is the reinforcement sensitivity theory, which is based on neurobiological and behavioral data that can then be associated with personality. So it's a nice intersection between all these types of research to try to understand behavior. So what the theory talks about in a nutshell is that there are systems, neurobiological systems that mediate certain types of behavior. And each of these systems is a collection of brain structures. So one of these systems regulates defense behaviors, which is called the fight, flight, freezing system. Another one that regulates approach behaviors called the behavioral approach or activation system. And there is a last system called that regulates mediation when these other two systems work at the same time, called the behavioral inhibition system. Now, because we're all students presenting here, I thought I would give you an idea of what each of these systems do based on an experience that we could have in everyday situations. So imagine when the university opens, we just want to go for food at Cambry, and because we're quite hungry. So when we do this action to actively go and get food, it's our approach system that is working. Now imagine as you're getting to Cambry into the restaurant that you see your supervisor. Now here, your defense system might be triggering because you suddenly realize that you were supposed to send that draft chapter last week. So here you have a couple of options: either continuing your quest, going for food because you're quite hungry and experience the consequences of your actions, or actually just leave the situation altogether and just go to a different restaurant. And this is where this mediation system will help you choose between, escaping a situation or just going for food. Now, because each of these systems do have a bit of planning and decision-making involved, they all are somewhat related to the part of the brain in the front, which is called the prefrontal cortex. And the other brain areas roughly associated with the defense system are these two, particularly the one along this part of the brain in the brainstem, because it deals with fight or flight responses that are quite quick. For the approach system, it involves roughly these other areas, quite deep within the brain. And for the mediation system, it involves these other areas that are a bit more temporal in the brain. Now, this is the full list of all the brain areas that are associated with each of these systems. And I think at this point, you might think, well, we know a fair bit about these systems. What is the point of doing any further studies? And this is because what we know about these systems is based on animal studies. So what I want to do with my PhD is just to see whether these systems actually are similar in humans, because these studies were done in mice. So, you know, mice brains and human brains are quite different. So how we went about this is we actually looked at adults. So this is a sample of people that actually live here in Canberra and Queanbeyan, and they're aged between 44 to 48 years of age. And they completed the behavioral inhibition and behavioral activation scales, this is just a rough sample of some of the questions, that we restructure to measure the defense system with 2 questions, the approach system with 13 questions, and the mediation system with 5 questions. Now, they also had some magnetic resonance imaging done, just to get an idea of their brains. And once we had these images, we used a software called FreeSurfer, which let us identify and quantify each of these brain structures in terms of volume, like how big these areas are. So now that we have an idea of measurements, we wanted to create, to find the association between system and brain structure. And we used multiple regression to do those types of analysis. And we looked at a couple of models. So there is the base model controls for age, sex, and head size, because these are the main variables that change between people for brain size or for brain structure changes. And then we looked at a more controlled model that additionally look at cardiometabolic health measures, such as hypertension, diabetes, BMI, and so on. And then we looked at each of these systems and which of the regions that could be theoretically linked to them in these subsets. So for the defense system, we look at 3 areas, and for the approach and mediation system, we look at these other 4 areas of the brain. So what did we find after a lot of analysis? So for the defense system, what we found is that one part of the brain called the anterior cingulate cortex was linked to this system, but only in the left hemisphere, which roughly looks like this area of the brain over here. For the approach system, we found an area called the caudate, which is deep within the brain, but in both left and right hemispheres to be linked to this system. And this is where they roughly are located in the brain, quite deep. And finally, for the mediation system, we found this area called the posterior cingulate cortex in the right hemisphere to be linked. And that looks roughly around that area. But we also found that another structure called the hippocampus was linked to this area, but only when there were differences in the size in the right hemisphere versus the left. And that is roughly where you can find it in the brain. So that was a lot of quick information, so I'll just do a bit of a recap, a bit of a conclusion. So we find support for some of the predicted associations based on theory, which is not a little finding in itself, like I said, considering that all this data is based on animal studies in mice, and now we're just finding some predictions that make sense in humans. So what it means is that if you have high scores in this defense system, is linked to larger anterior cingulate cortex in the left hemisphere. High scores in the approach system are linked to larger caudate volumes in both hemispheres. Higher scores in the mediation system are linked to larger posterior cingulate cortex in the right hemisphere, but also linked to larger hippocampus volume where the right hemisphere is larger than the left. Now, there was also some other areas that we didn't find associations, but this could be because the changes in those other structures are not readily detectable with the measures that we used. Some structures are quite heterogeneous in the way they work in the brain. And there could be like one part of the structure is linked to defensive behaviors, but the other part is a completely different function. So it's difficult to tell whether using the whole volume of the structure like we did here could actually lead us to association to each of these systems. So definitely there's a bit more of studies to look forward to as part of my thesis. But given the time constraints, I probably would leave it there. These are some of the references that I look at as part of my thesis. And I really would like to thank my panel members, Nick, Peter, and Mani, and of course, Richard, that really helped me understand all the analysis that I had to do for my thesis. And yeah, thank you.
Thank you, Daniela, for your nice presentations. Now, I would like to have questions from Daniela. Yes. Sarah, please. Hello, Sarah, please go on with your question.
Oh, no, I don't have a question. I was just clapping my hands.
Okay. Daniela, any hands up? No, okay. So can I ask you a question like how this theory about consumption of food, is it similarly applicable for when we eat at home environment, I mean?
I guess it could be linked to the type of, I guess, personality that you would have. I guess it just here is whether you're thinking about people that generally eat fatty foods regardless of the environment, whether being at home or being at social settings,
yeah,
or whether it's someone that will just eat fatty foods when when they're just with friends, which could be a different situation. So I guess using this theory, you could get an idea of who would be most likely to just consistently eat fatty foods, which would be linked to a particular type of system. Let's just say the approach system, because you really want to eat fatty foods, whereas someone that could be a bit more risk averse, and it would only do it in certain situations where they get social pressure to eat fatty foods. So it's a bit more of like, it's not deterministic in the sense that if you have this personality type, you're going to do this, but it helps you understand a bit more of why people behave in such a way.
Yeah, fantastic. Yeah, Mark, please.
Hi, Mark.
Mark has a question.
Hi, Daniela. Yeah, thank you. Interesting presentation. Why do you think the hippocampus had an impact only when the hemispheres were different sides, when the right hemisphere was larger? That's sort of quite interesting.
Yeah, it's actually, that's what I'm trying to grapple with at the moment, just trying to understand why that only happens when there are differences between the hemispheres. And I think it might be something to do, with lateralization of functions. I'm a bit hazy specifically on when the right hippocampus is more prevalent than the left for certain types of functions. But I think it might be due to that, because this is linked to, the mediation system that would be more linked to conflict resolution. So it might be due that the right hemisphere is more important for this type of behavior, but only in comparison to the left. So it might be that when both are the same, it just means that they're both working normally and there's not necessarily an association with this system, but I think it has to do something with lateralization of functions within the brain.
Thank you.
Thank you.
Thank you, Daniela, and thank you all for being with us in this morning session. And now we would like to have tea break. I mean, morning break. It will range 11:15 to 11:30. And then we will come with our second session, midday session. Yeah, and next session will be chaired by Rainy and Chetan. So till then, stay with us, have tea, and we will meet again. Thank you so much.
Thank you. Again, good morning, everyone, and welcome to the midday session of the conference. So I'm Maureen Matyong, and I will be the chair for this session with Shitan as co-chair. So I hope you guys had a great break and more importantly, had a chance to digest the wealth of information discussed by our awesome presenters earlier. Well, personally, what I've learned from the previous session is that there's a wide range of studies being conducted by our students in the school, from the analysis of discrimination to immunization systems, to biosensitive food systems, TB treatment, and study related to brain and behavior. So now that I think you have a feel of the diversity of the presentations, we would like to welcome you again to the next batch of presenters who will definitely give or discuss their field of expertise. So without further ado, I'd like to introduce our first presenter for this session, who will discuss the risk factors of Campylobacter jejuni and cholera infections in Australia. So please welcome Danny Cribb.
Thanks, Rainey. I'll just get my screen. Okay, can everybody see that? Excellent. Great, so good morning, everyone. My name is Danny, and I am a PhD candidate from the Infectious Disease Epidemiology and Modelling Group in NSEF. Firstly, I'd like to just pay my respects to the Yugara people on whose lands I am presenting from today in Brisbane. I'll be presenting some of the risk factors for Campylobacter jejuni and coli in Australia from a recent case control study that we conducted. So Campylobacter species are one of the most common causes of bacterial diarrheal disease worldwide. Australia has one of the highest annual rates of Campylobacter infections globally, with between 120 and 140 notified cases per 100,000 people per year. Taking into account underreporting, we estimate that there were nearly 359,000 cases in the Australian community in 2019. There are 26 known species of Campylobacter, with Campylobacter jejuni and Campylobacter coli well-established human pathogens, and they're also found in animal sources as well. Campylobacter infections often manifest as a self-limiting acute gastroenteritis, which means that they generally run their own course within about 2 to 7 days. The common characteristics are diarrhea, vomiting, nausea, and fever. Although uncommon, more severe infections are possible and can be accompanied by blood in the stool, high fever, weight loss, and persistent cramping. For those that haven't heard of Campylobacter before, you may think that this sounds a lot like Salmonella. And while the disease characteristics and sources are similar, Campylobacter is the more commonly reported bacterial pathogen in Australia. This graph here shows that the annual incidence of both Campylobacter and Salmonella have generally increased over time. Our case control study aimed to identify the most common risk factors for sporadic campylobacteriosis to inform public health advice and disease control strategies. We recruited 571 cases with culture-confirmed Campylobacter infection from state and territory health departments in the ACT, Hunter New England region of New South Wales and Queensland between 2018 and 2019. Culture confirmation is where the microorganism is able to be grown in the lab from the samples collected. We determined species from cultures that were whole genome sequenced, which is where the entire genetic code of the organism is captured. Of these cases, most were infected with Campylobacter jejuni. The cases infected with Campylobacter coli were slightly older and more likely to be male than Campylobacter jejuni. To understand the risk factors of infection, we recruited 586 controls that were frequency matched for age, sex, and location from notified cases of influenza within the 6 months prior to interview. Cases and controls were interviewed over the phone from questionnaires designed to investigate sources of Campylobacter infection, including questions on water sources, dining locations, meat consumption, and animal exposures. We identified factors associated with both an increased and decreased risk of Campylobacter infection, but I'll be focusing today on just those associated with the increased risk, which are those with an odds ratio elevated above 1. All factors are adjusted for age group, sex, location, and season in a multivariable model. We performed the same analysis on all of the Campylobacteriosis cases, and then separate analysis for the subsets of Campylobacter jejuni and Campylobacter coli cases. I present the results here for all of the cases except where the individual species is identified. The use of proton pump inhibitors, which are a type of medication that reduce stomach acid production for reflux patients, is associated with an increased risk of infection. Patients often use proton pump inhibitors on a long-term basis, and overprescription is a known problem. PPIs work by increasing the pH of the stomach, making it less acidic, which accommodates Campylobacter growth and likely allows enterics through the stomach into the bowel. This mechanism makes it a biologically plausible risk. PPIs as a risk for Campylobacteriosis is not a novel finding, with other case control studies and systematic reviews from around the world reporting similar results. The attributable risk is a measure of how much disease may be linked to a particular risk factor and helps to understand the total magnitude of infection by that factor in an entire population, and in this case, in Australia. When presented as a fractional percentage, it allows us to determine what % of Campylobacter could possibly be prevented if the risk was removed from the population. The adjusted population attributable risk of PPI use suggests that they are responsible for 13% of all Campylobacter cases in Australia. This equates to roughly 46,000 community cases as of 2019. Moving on to chicken, we identified that eating cooked or undercooked chicken was strongly associated with Campylobacter infection. Chicken is a well-known reservoir of Campylobacter, and regardless of how often it is consumed or how it is prepared, it remains a risk across Campylobacter species. Chicken is a commonly eaten meat in Australia, with 34% of Campylobacter infections likely due to eating chicken. According to our 2019 estimate, this equates to around 120,000 community cases of Campylobacter. You can also see that undercooked chicken was very strongly associated. However, we have a high level of uncertainty around the point estimate due to fewer cases of control responding to this question, which is likely due to recall bias. Animal factors related to infection include contact with chicken feces and ownership of puppies. Importantly, animal exposures do not remain statistically significant when restricted to Campylobacter coli infections. However, the uncertainty around these values is likely due to a lack of power within the Campylobacter coli subset. We observed the association for young pets in particular, and this is likely related to the higher carriage load of the pathogens in the puppies themselves due to a developing immune system and lack of toilet training. This risk attenuates as the pets get older. Some delicatessen products carried an increased risk of infection for Campylobacter coli, including consumption of deli meats and chicken pate. As these factors did not remain significant in the Campylobacteriosis full model or the Campylobacter jejuni models, it is possible that Campylobacter coli has an increased presence in these meat-based products. So to date, few case control studies of Campylobacteriosis have differentiated risk factors between species. As discussed, the differences in risk factors are possible, and this can have an impact on control strategies, particularly for Campylobacter coli, which remains an important human pathogen despite accounting for a smaller proportion of cases. These differences should be explored further in higher powered studies. Advances in whole genome sequencing technology will continue to change and improve the way we handle foodborne disease surveillance, allowing for earlier source identification and case linkage in outbreak settings. From here, our study team plans to conduct detailed analyses of the whole genome sequencing data from these pathogens to allow us to better understand the driving factors of Campylobacter infections in Australia. A source-assigned analysis will combine the reservoir-level source attribution data with the individual-level case control study data to enhance the public health utility of these data to identify pathways for transmission. The take-home messages from today is that while Campylobacter infection is primarily a foodborne pathogen in Australia, or a foodborne illness in Australia, animals, including domestic pets and regular medication use for stomach acid regulation, also carry a heightened risk for infection. We should ensure that contamination in the poultry production chain is minimised and that public health messaging around proper food preparation and the risks associated with young pet ownership and proton pump inhibitor use is communicated widely. This work wasn't possible without the CampySource project team, so I would like to extend my thanks to them and for everybody in the audience here today. Thank you.
Thanks, Danny, for very interesting presentation. So we would now open the floor for some question and answer. So we have Daniela.
Oh, no, sorry, I was just clapping. It was a fantastic presentation.
Thank you.
So we have here Gisem.
Okay. Hello. I'm Satay.
Hello. Yeah. I can hear you. Yeah.
Yeah. Thank you, Rani, for your nice presentation. And I think with regard to your study population, I'd like to know why only males are participated in your study.
So could you just repeat that one?
Yeah, about your study population.
Yeah, about the study population.
What about females? My question is, what about females?
Females? Yep.
Yeah,
so,
just for the sake of it.
Yep, sorry.
Yeah, keep going.
So about the females in the study population, is that the question?
Yeah.
Yep, so there were females and males in the study population. It was about even, except there were slightly more males for Campylobacter coli.
Okay.
Yep.
Okay, I have another question, Danny. You have mentioned about the 13% attributable risk for the PPI proton inhibitors. So I was wondering what's the actual population of Australians who are receiving treatment for PPI, if you have that information?
Yeah, I don't have the exact number, but there has been a recent review done looking at the 45 and up study, as well as the PBS data. So I'll be using those estimates to have a look at that. But it's definitely not the entire population. Obviously, there's a smaller subset, and generally it is in older adults as well. So, 50 and up are the ones that use it. But yeah, it is a smaller subset of the population. But yeah, it's a big risk for that subset.
Okay, thank you. I think there's no more question. And now I think we can proceed with our next presenter. Thank you, Dani, for that interesting presentations.
Thank you.
So our next presenter is Katrina Howe, and she will talk about the extent to which off-patent registered prescription medicines are used for off-label indication in Australia, which is a scoping review. So the floor is now yours, Katrina.
Thank you. I'll just share my screen. Can everybody see my screen now?
Not yet.
Not yet.
Can you see it yet?
No.
Yep.
No.
Still no.
Sorry.
Not yet.
Okay, sorry. All right. Let's see. Yeah.
Yeah.
Okay, apologies, everyone. I'd like to begin by acknowledging the traditional owners of the lands on which we meet today and pay my respects to elders past and present. I'm pleased to present the results of this scoping review on behalf of my co-authors, Dr. Siobhan Burke and Emeritus Professor Lloyd Sansom. We have studied the extent to which off-patent registered prescription medicines are used for off-label indications in Australia. To provide you with some background, this graph illustrates worldwide prescription drug sales in billions of US dollars over the last decade and out to 2026. Market segments presented here are prescription drugs, excluding orphan drugs and generic drugs, which are original products protected by a patent, orphan drugs, which are also protected by a patent and used to treat rare conditions, for example, in Australia, conditions affecting fewer than 1 in 2,000 patients, and generic drugs, which are copies of the original product brought to market after patent expiry. These are also called off-patent drugs. You can see that for this year, 2021, sales were forecast to reach just over $1 trillion US. Prescription and orphan drugs represent the bulk of these sales. Generics were estimated to make up less than 8% of worldwide sales in 2021 and show relatively flat growth over time. The forecast growth in the sale of prescription drugs and drugs for orphan indications is likely to continue to impact the world's economies. Generic off-patent drugs represent a sustainable way of providing patients with access to safe and effective treatments at relatively low cost. Governments around the world are continually looking for ways to put downwards pressure on drug prices. Interest is growing in the repurposing of drugs, particularly lower cost off-patent drugs. Drug repurposing is an Australian Medical Research Future Fund priority and has recently been the focus of a parliamentary inquiry and a public consultation by the Therapeutic Goods Administration, the TGA. Drug repurposing, put simply, is the use of an existing drug for a different therapeutic purpose. Drug repurposing can involve reformulation of an existing drug and use at a new dose or via a new route of administration, and repositioning of an existing drug for use in a condition which is distinctly different from the original indication for use. My interest is in the repositioning of off-patent prescription medicines for off-label indications in various clinical settings. In Australia, medicines must be submitted by a sponsor and assessed by the Therapeutic Goods Administration for safety, quality and efficacy before they can be included in the Australian Register of Therapeutic Goods. Prescription medicines need to be registered in order to be lawfully supplied and subsidised by the Australian Government through the Pharmaceutical Benefits Scheme. Prescriptions for public hospital inpatients are not covered by the PBS. Instead, they are funded by state and territory governments. The registration label for a medicine describes the indications, dose, route of administration, or patient group set out in the TGA-approved product information. For prescription medicines that are no longer patent protected and have lost market exclusivity due to the availability of generic versions, sponsors tend not to invest time and/or money into the process of submitting data to the TGA to have new indications or other therapeutic uses added to the registration label. Legally, medicines can be prescribed for uses beyond the limits of their registration. This clinical practice is known as off-label prescribing and is a form of medicine repurposing. Off-label prescribing may be beneficial for patients when there is no alternative treatment and some scientific and medical evidence exists to support a particular off-label use. However, off-label use is not PBS subsidised and can have out-of-pocket cost implications for patients if alternative funding is not available. Our study looked at the use of off-patent prescription medicines for off-label indications. The medication off-label indication dyads identified through this work will be referred to as repositioning cases throughout this presentation. The aim of this scoping review was to determine the extent of off-patent prescription medicine use beyond registered indications in Australia. This review identified numerous repositioned medicines in current use in clinical settings. To date, there have been no other systematic reviews examining the extent of use of off-patent prescription medicines for off-label indications in Australian clinical settings. This scoping review followed the Joanna Briggs Institute approach. A protocol was prepared describing the inclusion-exclusion criteria, search strategy and sources, evidence screening and selection process, data extraction, synthesis and presentation of results. The review was reported using PRISMA for scoping reviews. This methodology enabled a systematic summarisation of the evidence, providing reproducibility whilst allowing flexibility to broadly explore all publicly available sources of evidence on the topic. Evidence was included if it described patients treated in Australian public hospital, community or primary healthcare settings with off-patent registered prescription medicines for off-label indications. The name of the medicine and the condition or disease being treated had to be stated for inclusion. Data sources included published academic and grey literature, as well as publicly available statewide medicine formularies. Medicines on statewide formularies are approved and funded by state and territory governments for use in public institutions. The results of this literature search are shown here. References were identified from searching Medline, Scopus, and Web of Science. Google Scholar, websites of Australian government agencies, Australian academic institutions, plus organisations such as the Council of Australian Therapeutic Advisory Groups and the National Prescribing Service, NPS MedicineWise, were also searched in July and August last year. Duplicates were removed and references were screened. Only 14 references satisfied the eligibility criteria. Of the included references, there were 11 in one or more Australian public hospital settings, 2 in the palliative care setting, and 1 in the community setting. Interestingly, there were none in the primary healthcare or general practice setting. Overall, we found 32 off-patent prescription medicines were used for off-label indications. Rituximab, a monoclonal antibody drug product, was reported most often. In total, there were 128 repositioning cases identified. Rituximab was used off-label in 29 of these, and infliximab was used in 2. The only statewide medicine formularies that were publicly available were the Queensland List of Approved Medicines and the South Australian Medicines Formulary. Comparison of published literature with off-patent prescription medicines used for off-label indications from these formularies was important in order to get a measure of the extent to which off-patent medicines are approved and funded for unregistered indications across Australia. We found 10 different off-patent prescription medicines approved on the Queensland List of Approved Medicines for 17 of the same repositioning cases that were reported in the literature. Only 2 of these repositioning cases were from studies just conducted in Queensland. This suggests that these off-label uses are possibly approved and funded in clinical practice in other states. 7 different prescription medicines were approved on the South Australian Medicines Formulary for 21 of the same repositioning cases that were reported in the literature. Only 5 of the repositioning cases were from studies just conducted in South Australia. Overall, there were only 5 repositioning cases in common to both statewide formularies. The use of off-patent prescription medicines for off-label indications appears to be a much broader clinical practice than has been reported to date in the literature. We also looked at prescription medicines on formularies for off-label indications that were not reported in the literature. An additional 28 repositioning cases were found on the Queensland List of Approved Medicines and 14 on the South Australian Medicines Formulary. There were only 2 repositioning cases common to both statewide formularies. In Australia, due to jurisdictional differences in the management of statewide formularies, access to off-patent prescription medicines for off-label indications can be inequitable. Access appears to depend on where you live. In conclusion, the extent to which off-patent registered prescription medicines are used for off-label indications in Australia is greater than previously reported. Usage and funded availability of certain medication off-label indication dyads varies across Australia. These results further expose the two-tiered system of medicines regulation in Australia, that is, TGA approval at the national level versus local, state and territory approval. These arrangements have an impact on equity of access to medicines. Further research into policy options to encourage submission of registration updates for off-patent medicines is required. Unless registration information for off-patent medicines that are commonly used off-label is updated, treating physicians will continue to repurpose prescription medicines in day-to-day clinical practice for off-label indications, and patient access will remain inequitable. These are my references. Thank you, and I'm happy to take some questions.
Thanks, Katrina, for that interesting presentation. So the floor is now open for Q&A. So we have from Emily. Please go, Emily.
Thank you so much, Katrina. That was a fantastic presentation. I'm just wondering if you could talk a little bit more about the lived experience of this inequity and what it means for patients and what a difference in that policy would mean for patients.
Thanks for that question. I think it's really important. I guess from a patient perspective, it would mean the difference between accessing a drug for a rare disease, for instance, or not. So I can give you an example. In Queensland, rituximab, which was the most frequently reported drug, is available for a rare condition called TTP, thrombotic thrombocytopenic purpura, but it's not available in South Australia for that particular condition. So if you were a patient in South Australia with TTP, you would either need to try to access that drug through individual patient use applications to the South Australian Medicines Committee, or you'd have to fund it yourself. So there are a number of patients around Australia that are self-funding their treatment. Some people reverse mortgage their houses and have to pay thousands of dollars a week for treatment. And this inequity is quite frustrating for them if they find out that, you know, just because they live, say, in South Australia or New South Wales or Western Australia, they're having to pay, and patients in other areas are actually being provided with funded treatment.
Thanks, Emily, for that question, and Katrina. Also, we have another question from Angus.
Hello, Katrina. Thank you for that presentation. It was really clear and really insightful. Yeah, really interesting. I have a question about sort of, I suppose, perhaps about, I don't know, alternate mechanisms for, or pathways for these sort of off-label prescriptions to be recognised and therefore funded by the government. If I understand correctly, it's the drug companies which put them forward for consideration. Are there sort of other mechanisms that to, I suppose, give some impetus to get them onto the MBS? And what do those look like? And I suppose grassroots alternatives and things like that.
Yeah, thanks for that question, Angus. Actually, that's one of the questions that I'm going to be looking into through my PhD. At the moment, it is the responsibility of a medicine sponsor to make an application to the TGA to have the registration label updated. However, alternative pathways do need to be found. Through some of the consultations that I mentioned, alternative approaches have been suggested, such as groups of clinicians being permitted to make applications to the Therapeutic Goods Administration to have a particular drug registered for a particular use. I guess at the end of the day, it comes down to who's going to take legal responsibility for the use of that drug if that registration is approved, if it wasn't the medicine sponsor that made the application. So alternative mechanisms for having drugs that are in wide clinical use for off-label indications recognised for that use and funded would improve patient access, would remove the burden that's currently on clinicians when they prescribe off-label. They have to take personal responsibility for those prescribing decisions. And we do see around the world that different countries and different groups, such as the EMA, are very interested in drug repurposing and finding a way to encourage this without, I guess, putting unacceptable burden on sponsors that maybe have moved from that therapeutic area to a new therapeutic area and don't want to invest, as I said, the time and the money into making those changes. So it is a wicked problem, and it's something that we need to work on. It's an important area.
Oh, thank you. That's as you say, a difficult problem to address.
Okay, thanks Katrina and Angus and Emily for the questions. I think let's proceed with the next presenter. Our next presenter we're going to talk about a systematic review on the association between educational level and multi-morbidity among adults in Southeast Asia. So please join me in welcoming CU Feng. See you when you're ready.
Hello everyone, can you hear me? Yeah, maybe you can hear. Next I will share my screen, sorry. It's okay? Yeah. Hello everyone, my name is Xu Feng. I'm the first PhD student in the Department of Global Health in RSPH. Today the topic of the presentation of the student conference is the association between educational level and mortality among adults in Southeast Asia, a systematic review. Yeah, and the supervisor of this topic is Dr. Kelly and Dr. Sama. And I will present this topic in 6 parts. For the introduction, mortality is usually defined as a presence of 2 or more health and chronic health conditions in one person at the same time. Mortality is more common in older people, often more than 6 years old. Due to global aging, mortality is also become a global public health issue. The magnitude of mortality in low and middle income country is estimated to at 10% to 11% recently. Because of complexity of symptom, high mortality rates, and more complex treatment requirements than single conditions, patients with mortality often do not receive cost-effective treatment. In Southeast Asia, the prevalence of mortality is gradually increasing. About 4.5% at the early of the 21st century to about 10% in recent years. The major factors of mortality are rapid socio-economic development of region and the concurrent growth of socio-economic inequality. Education level, which is a key indicator of socio-economic status, may have a greater impact on the prevalence of chronic disease compared with other 2 factors, means income and occupation of SES. There are 2 reasons of that. Firstly, educational level also usually lead to high income and wealth. The other one is that educational level often lead to health literacy even without any risk in income or wealth. Educational inequalities are evident in Southeast Asia and possibly influence of mobility. In Southeast Asian nations, disparities in access to educational resources are common. Thus, education level will be used as exposure factor to measure its effect of mobility in this place. As for method, it is a systematic review without mental analysis, and this part will divided into 5 parts. As for the inclusion criteria, it has six parts, and the exclusion criteria also has 6 parts. And for the search strategy and the selection of literature, the database of Scopes, PubMed, and ProQuest were used to search for relevant articles. We classified the search term according to education as exposure, mobility as outcomes, and Southeast Asia as location. The study in this paper only involved human participants, were published from January 1st, 1990s to June 15, 2021. As for the assessment of quality, we assess the risk of bias and study quality using the Newcastle Outward scales. As for data extraction, we extraction the following information from these 10 items. As for data synthesis, the findings regarding mirth, exposure, and outcomes were described using narrative synthesis, but prevalence, mobility, the prevalence of mobility at the different educational levels, and the results of mobility at different educational level were extracted from individual studies. Yes, for the results, the electronic and manual searches yard 7558 articles, 36 articles were found to be available for task reviewers review. 18 articles were included in the systematic review. 17 papers were cross-sectional studies, and only 1 paper was the longitudinal study. And as for the prevalence, all of the participants were prevalence of mobility, and the prevalence of mobility ranged from 1.7 to 72.6% among over 18 years old. Moreover, the prevalence ranged from 1.5% to 51.5% among older people. Yeah, it's a and as for the association, there are 3 outcomes of the studies. The prevalence, the first one is that the high education level reduce odds of suffering from mobility. The second one is that low education level reduce likelihood of having mobility. And the third one, the education level was not related to mobility. And for discussion, the improvement of education level could effectively prevent the occurrence of mobility. People with lack of health knowledge usually suffer from higher stress levels and the inability to afford health and nutritious food. Thus, they may be more likely to suffer from mobility, but some studies in Southeast Asia, the relationship of mobility and the educational level was inverse. Firstly, under research of mobility in these countries, which results in a diversity of results between educational level and mobility. Second one, high educated people in this country and regions tend to favor inactivity life habits. And these people also have better access to medical care and better health knowledge. As a result, these highly educated people are more likely to receive and report a diagnosis of their conditions. The main strengths of this paper include the systematic listing of educational levels separately in relation to maternity rather than include it in the SES. However, the limitations are also obvious. The inherent bias in the estimated of the original study prevents thus assessment of quantification of prevalence of malmobility and the estimated of the association between education level and the malmobility. The other limitation is that it was difficult to ensure that all relevant literature was included. For the implication, the panel of chronic conditions should be prepared with a standardized definition of each disease and a uniform operational definition of malmobility. In addition, it should be a uniform and objective criteria for the classification of educational level. And for the conclusion, the study is a comprehensive mapping of research related to malmobility in Southeast Asian regions and reverse the neglect and the inadequacy of research on malmobility in the region. The prevalence of malmobility range widely in this study, and the association between educational level and malmobility were inconsistent. But we can know that it is predicted that a sound and complete educational system can help people to raise health awareness that thus effectively prevent malmobility. And to my research for the last one, yeah, my research is malmobility in Thailand. The database includes Thai cohort study and Thai hospital data. The further research should answer these following questions. Firstly, what the prevalence of malmobility in Thailand? What are the prevalence risks? What are the primary risk factors for malmobility in Thailand? What role does educational level playing in predicting malmobility in Thailand? What is the geographical distribution of malmobility in Thailand? What are most common components of malmobility in Thailand? And if answer these questions, appreciate and a reasonable recommendation would be given for establishing improved guideline for the protection, treatment, and the care of malmobility in Thailand. This is all my presentation. Have a good afternoon, everyone. Thank you so much.
Thank you, CU, for that informative presentation. So anyone, do you have any questions for CU? So we have here Daniela Espinosa. Please go ahead.
Sorry, again, I'm just clapping. Apologies. Okay. I'm going to stop doing that. Apologies. So I'm just going to do like an actual clap. That's a fantastic presentation. Thank you.
Thank you so much.
We have here from Linda. Please go ahead, Linda.
Thank you. Yes, it was a fantastic presentation and a
Thank you so much.
Really interesting topic. So, so I'm going to ask you about your conclusion and then what you found, because you found that education helped in some groups, but in other groups something else was going on. So the well-educated groups, there were these inconsistent findings. So what are the other risk factors that you think are at play? It sounds like just like you've got multi-morbidity, you've got multi-causality going on in your data, and that just one single, if you like, social resource such as education is not enough to explain what's really going on. So what are the other social resources and risk factors that you think are going on to drive multi-morbidity?
Yeah, Yeah, for me, I think the education level with one I talk about, and the income and occupation. Yeah, we also inform for the for my slides, and other I suppose is about the health of the lifestyle factors. Yeah, so sometimes for the ask people to do more activity instead of inactivity lifestyles, maybe better for them to prevent mortality. But I think the education may be the best one, because we can do this from the education because education when I started when we were a child. Yeah, so it's a long way for us to make or to build a group for us to prevent this disease. So it's my thoughts. Thank you so much.
Okay, thank you, Lyndall and CU. We can accommodate one more question. Yeah, please go ahead, Grace.
Hi, thank you. Thanks for that great presentation. I would just like to clarify on your kind of where this research would inform. So you are interested in predicting multimorbidity, right? So obviously, like the cause, it's not really the causal mechanisms that you're looking at. It's more about predicting the prevalence of multimorbidity. Is that right?
Yes.
Yeah. So how I'm just curious about where you would see the result. Where would you see the implication of it? The results being used, as in so you're not trying to really kind of implement something to reduce the prevalence of multimorbidity. It's more about predicting the levels. So how would you be using your results? Thank you.
You mean that how to reduce the prevalence?
No. What are you trying to inform? Where would you be using your results on predicting multimorbidity?
Predicting multimorbidity. I use this source. I use this source from the maybe to use the guideline to reduce the mortality prevalence, or maybe the range from my paper is from my topic, the range is large, since this paper I didn't use the meta-analyze, but I saw other papers from the prevalence and mortality. So for the systematic review and the meta-analysis, they said that now the prevalence and mortality is was from 10% around the developing countries.
Okay. I'm sorry that we ran out of time for the Q&A. If you have still questions for CU, you can contact her after the conference. So I think let's proceed with our next presenter. Our next presenter is Seten, and he will talk about characterizing TB and HIV susceptibility by using genome-wide association study evidence for systematic review and analysis. The floor is now yours, Seten. I think you're on mute. You're on mute. I think you're on mute, Seten.
Sorry. I think, can you hear me?
When you're ready, please.
Yeah. I'm Satay. I'm first year PhD student. I'm working from Ethiopia. I'm pursuing offshore program. I would like to present our recent work entitled with characterizing TB and HIV susceptibility by using genome-wide association study, evidence from systematic review and meta-analysis. These are some of the discussion points. To start with background information, the transmission dynamics of infectious disease, namely TB and HIV, can be determined by multiple factors, such as genetic factors, immunity, environmental factors, socio-economic factors, behavioral factors. And on the top of that, genetic polymorphism or genetic components has the principal impact on the disease susceptibility. And previous genome-wide association study investigates the genetic framework of complex disease traits like tuberculosis and HIV. For instance, TB susceptibility is more common in monozygotic twin than dizygotic twin. This highlights the role of genetic risk factors in TB susceptibility. Similarly, there is also evidence with regard to variation in individual susceptibility to HIV infection. There are groups that can be considered as susceptible. There are also groups resistance population. And based on progression, some people are fast progressor, some are slow progressor. And there are reports that reveal that some genetic polymorphism, such as CCR5 polymorphism, confers resistance to HIV infection. Previous genome-wide association study have identified various SNPs or single nucleotide polymorphism associated with TB and HIV. However, due to lack of the power or due to small sample size, the results are so variable and inconsistent across the states. That's why we conducted this systematic review and meta-analysis to estimate which SNPs are robustly associated with TB and HIV susceptibility. And to conduct this study, we retrieved studies by using electronic database, PubMed, Medline, Embase, CINAHL, and the JOAS catalog. And we defined inclusion and exclusion criteria. Studies reported minor alert frequency controls within the Hardy-Weinberg equilibrium were included. In contrast, the studies with a sample size lower than 10 cases or controls and with incomplete or non-reported data, non-English published reports were excluded from this analysis. Then we made a data extraction based on study features, for instance, like study name, SNPs, minor alert frequency, odds ratio, mapped gene, chromosome, location, p-value. The included studies were, assessed. That means the quality of the studies were appraised through a tool, special designed for genome-wide association study. This tool is called a QGenie tool, and it has about 11 questions. So based on the quality of the included studies, we rate the quality. Whenever the quality is below 35, it's considered as poor. Between 35 and 45, it's considered as moderate, and above 45, it's considered as good study. Then we carried out data analysis, and we used R package, space package, meta package, and we estimate the pool odds ratio and the 9-5 confidence interval based on SG method or Siddick-Jogman method. Important, especially whenever we assume there is variance between studies. So coming to the result and discussion, we have identified around 10 SNPs were replicated across TB JOAs. And one of significantly associated SNP is, just for convenience, I will read the last 3 digits. RS426 risk allergy had a genome-wide significance level with increased TB risk. That means the odds ratio or the combined effect is above 1.1. And this polymorphism is located within intragenic genomic region or non-coding region. And its mechanism remains unknown, but previous studies showed that mutation, particularly on chromosome 1H, were linked with the prostate cancer. Another SNPs, RS178 risk allele A, this also significantly associated with TB, lower TB risk, with odds ratio around 0.8. And this SNP is associated with a gene, a marked gene known as PAM7P. And another SNP is RS728. This also located on the same chromosome like the previous SNP, though the effect size was not significantly associated, but it shows, marginal. That means it is associated with lower TB risk, and the reason is that the gene, the polymorphism is located within a gene WT1. And this gene is very important, especially for regulation of immune system against Mycobacterium tuberculosis. We have conducted also ethnic specific TB analysis, especially RS426 risk allergy also demonstrated high TB risk in sub-Saharan Africa, whereas not significantly associated in East Asian samples. We have also seen other SNPs, 7 SNPs, which belong to the single gene, ASAP1 gene. This gene also associated with TB risk reduction, and the scientific background for this TNRO. This gene is actually important for normal functioning of podosome. Podosome is one of the most important macromolecule, or the protein, which is important for upregulation of immune system, especially for the activation of dendritic cell and the macrophage, which are the vital immune cells to contain the Mycobacterium tuberculosis, the bacteria. We have seen also HIV, and we have only identified on 2 SNPs that were replicated by the included studies, and the 2 SNPs showed a decreased risk for TB, for HIV susceptibility, and the combined effect is actually around 0.9 and 0.74. In conclusion, this study highlighted SNPs associated with altered risk TB, with the risk of TB and HIV infection. However, the patient still exists on their biological pathway, and this insists the need for in-depth study or large-scale dual studies. Finally, I would like to thank my supervisors, Professor Darren and Dr. Cafialo, Dr. Abul Fazl, and Dr. Brett, and my collaborator, Dr. Andres Maret from University of Amsterdam, who helped me especially for data analysis and interpretation, Australian National University for funding my PhD program. And finally, I would like to thank also the conference organizing committee. Thank you very much.
Thank you so much, Siten, for that presentation. And thank you for joining us from Ethiopia at a different time zone. To keep with the time, you can only accommodate one question. So I'm seeing here Brett. Please go ahead with your question, please.
No, again, it was just me applauding, so I didn't raise my hand.
Okay.
No question from me.
All right.
I have plenty of opportunity to ask certain questions other times.
So I think if none, so let's proceed to the next presenter. So our last but definitely not the least presenter for this session is Tianyin Wang, and she will talk about the relationship between work-family conflict and the likelihood of a depressive or anxiety disorder. So the floor is now yours, Tianyin.
Hello, everyone. Yeah, I just try to share my screen. Hello, everyone. It's my pleasure here to share the initial findings of my PhD research. I'm Tianyin and supervised by Lena. And first, I will introduce some background about my research. In recent decades, the demographics and working patterns of workers in Australia have changed. Some of these changes include longer working hours, greater flexibility in work schedule, and a growing proportion of females participating in labor market. These changes in the gender composition of the labor market mean that more parents are juggling both paid work and caring responsibilities than ever before. This is especially the case for mothers. And this increase in dual job and family role obligations has led to a large body of research investigating the prevalence and drivers of work-family conflict. Work-family conflict is the pressure that comes from trying to manage incompatible work and family demands, which is viewed as a chronic role strain or stressor that could be reduced if individuals could better balance their multiple roles in their work and family. Research exploring the prevalence and sources of work-family conflict has also examined the potential adverse effects on individuals and families. Work-family conflict has been shown to be associated with psychological distress, including depressive and anxiety symptoms. In this study, I used the cutoff point of the Goldberg Depression and Anxiety Scale to determine a depressive or anxiety disorder, just like the level of depressive or anxiety symptoms. A further possible severe adverse consequences of work-family conflict that has really been examined is the relationship between work-family conflict and suicidal ideation. While studies including measurement of both work-family conflict and suicidal ideation are limited, some previous research suggests that work-family conflict is more likely to cause suicidal ideation, in particular occupation via depression or anxiety. The objectives of my research include two aspects. First, to investigate the relationship between work-family conflict and the likelihood of experiencing a depressive or anxiety disorder, controlling for a broad range of potential confounders, including exploring the relationship between work-family conflict and suicidal ideation. next part is the methods of my study. This study uses the personality and total health through life project data. The PASDAT project is a large ongoing population-based longitudinal cohort study comprising about 7,500 participants. And this study includes about 1,200 employed participants who aged 38 to 43 in wave 5. And the work-family conflicts using a measured by a scale of 4 items. The first 2 is for work to family conflicts, which is because of my work responsibilities. I have missed out on home or family activities that I would like to take part in, and my family time is less enjoyable and more pressure. The other 2 is for family to work conflicts, which is because of my family, including caring responsibilities. My work time is less enjoyable and more pressured. And I have to turn down work activities or opportunities that I would prefer to take part in. The depressive and anxiety disorder is determined by different cutoff points in the Goldberg Anxiety and Depression Scale. And the psychosocial job quality include 4 aspects: job demand, job decision, job skills, and job insecurity. Yeah, the first table is about the results, indicated the relationship between depression or anxiety disorders and the work-family conflicts. Sorry? In 4 and social demographic covariates, the odds ratio declined slightly, but all the association between work-family conflict and depressive and anxiety disorders remain statistically significant. The relationship between work-family conflict and depression continued to be significant after controlling for prior mental health 4 years earlier in Model 4, while the relationship between work-family conflict and anxiety was no longer significant in the final model. As expected, people with depressive and anxiety symptoms in Wave 4 were more likely to experience current depression and anxiety. The results also showed that the occurrence of depression or anxiety was related to job security and life events, such as break off a steady relationship or lost valuable things. This association was partly explained by physical health problems and emotional stabilities as well. Moreover, there was no gender differences in the likelihood of experiencing a depressive or anxiety disorder when people suffer from work-family conflict. The second table indicated the relationship between work-family conflict and suicidal ideation. Except life events, married status, and gender, the covariates controlled in Model 3 also include occupational skill levels, income, people who have children or not, parents who have children under 5 years old or not, work hours, housework distribution, and education level. After adjusting for psychosocial job quality, the relationship remains statistically significant. However, after controlling for social demographic covariates and current depression and anxiety, the association no longer significant. Compared to females, males are more likely to have suicidal thoughts, and people who have more stable emotion are less to consider suicide as well. Also, existing depressive disorder would lead to suicidal ideation to some extent. To conclude, this study used nationally representative Australian data to indicate that a higher level of work-family conflict in a depressive or anxiety disorder. Employed people who are less able to balance their work and family demands may be at high risk of these common mental health problems. Work-family conflicts would increase the risks of suicidal ideation via depression and personality was significantly related to the occurrence of those mental health problems and suicidality. Thank you, everyone. That's all of my presentation. So anyone have any questions?
Thank you, Tianying. The floor is now open for some questions to Tianying. Okay,
hi.
Question from Emily.
Thank you so much for that presentation. It was really, really terrific. Could you tell me a bit about what you think the policy and practice implications of your findings are? Like, what do they mean for people or for employers or people working in organizations?
I'm not sure exactly policy or this problem directly, but I just wanted to let people to focus on that. Yeah, nowadays the work-family conflicts can lead to adverse effects, not only just include some bad mood, bad emotion, but it probably will lead to the suicide as well. So yeah, because life is so valuable. Yeah.
Thanks, Emily, for that question. Anyone else? I think we have from Tin.
Yes, thank you for your very good presentation. Just a question. So when you look at the relationship between work-life, family conflict, and depression, so did you use the same level of data or you using less? So I suppose if you have high work, family conflicts, affect your depression, right? But if you are under depression, and then also affect your work life, family conflicts, right? So is that a two-way relationship? Do you consider how to deal with that?
Yeah, so you mean that if people have some mental health problem like depression or anxiety, they are more likely to suffer from those conflicts than others, right?
Yeah, the other way around. Yeah, and
yeah, probably the relationship could be that, but yeah, I will find more.
So I could suggest, you're using maybe 1 year lag or 1 or 2 year lag. So using like, 1 or 2 year lag of a work family conflict in previous years to predict the current depression. So that is you cut the reverse relationship, only one way relationship using previous year, work family conflict to predict the current year depression.
Yeah, I think that's a good point. Yeah.
Yeah. Okay. Thank you.
Thank you.
Thanks. We have another question from Lindo. Please go ahead, Lindo.
Sorry, it's for some reason with Global Protect, everything takes forever. So thank you, Tianying, fantastic. So I would really encourage you to work with Tin on teasing out the reverse relationships because he is the master of doing this. So definitely take him up. We have done some work where they do have reverse relationships, but they both matter. And so they compound, it's like a death spiral, basically. If you've got mental health problems or work-family conflict, they exacerbate each other and down people go and vice versa. You go back up if you can improve one or the other. Emily, I would love to tell you what I think the policy implications are of this work because it is such an extraordinarily important thing to do, and we actually have to change how we work if we really want to challenge the problems that people are confronting in their working lives. So too long would take too long to actually have that discussion, but this is part of one of the dilemmas around dealing with a social determinant of health, which is that it affects not just health, it affects so much of how we live, and therefore it's awfully hard to change. So anyway, for another time, maybe over a glass of wine, let me loose on that one.
Thank you, Lindo. Thanks for your explanation.
We can accommodate the last question from Liana.
Thanks, Tianying. That was really great. And I know that's the first time you've presented that. I just wanted to check, going to Tin's question, do you have work-family conflict at wave 4, or you only have it at that final wave? Is that correct?
Yeah, I just use the final wave, yeah.
So in the data set, my understanding is there's no measure of work-family conflict at wave 1, 2, 3, or 4. It's only at wave 5. Is that right?
Yes. Yes.
So, yeah, so there's some limitations in the data, Tin, that means that Tianying can't look at the reverse relationships. But my understanding of what you did was that you did try to control for depression and anxiety at the previous wave, kind of as a way of getting at that, current experience of work-family conflict and depression occurring concurrently, even if you can't really know whether the chicken came before the egg.
Because I can't control for previous conflicts. Yeah, only previous depression and anxiety I could control.
Do you have like a work-family conflict information from Hilda or not, Lena?
So this is from PATH, so we don't have any. So it is in Hilda, but at the PATH study, we've only just put it in the most recent wave.
All right, thank you.
Okay, thanks everyone for the questions, and thank you, Tianying, for that informative presentation. So I think the time is up for this session, and I think also this marks the start of our 30-minute lunch break. So we will resume again this afternoon at 1:15 for the remaining 10-minute presentation and the 3-minute presentation. So enjoy your lunch, guys, and thank you for your attention.
Good afternoon, everyone. Welcome back to afternoon session of the RSPH Student Conference. My name is Andini, and I will be moderating this session with Rain Matthew. For this session, we will have 2 more standard presentations. Then we'll have external guest lecture by Professor Michael Kidd, followed by Q&A session. After that, we'll still have 1 presentation in 3 minutes thesis format. So let's start this session. The first presenter is Chetan, and he will be presenting spatial and temporal patterns of dengue incidence in Bhutan. Time and floor is yours, Chetan.
Thank you, Andini. Can you see the slide now? All right, thank you. Welcome back, everyone, again after a short lunch break. I'm Setin, a third-year PhD at Research School of Population Health. Today, I'm going to talk on the spatiotemporal analysis of dengue in Bhutan. A bit of background on dengue. Dengue is a vector-borne disease transmitted through a bite of Aedes mosquitoes. There has been a dramatic increase in the frequency of dengue over the past decades. The global incidence has increased by 30-folds in the past 50 years. Before 1970, there were only 9 countries that had severe dengue epidemics. Now, dengue is endemic in over 140 countries, which are spread in Southeast Asia, the America, the Pacific, Africa, and Eastern Mediterranean region as shown in the map. The recent WHO estimates show that there are over 390 million infections and 10,000 deaths globally due to dengue. Talking about dengue in Bhutan, the map below shows the location of a place, which is highlighted in brown color, from where first dengue outbreak was reported in the country. The graph above shows the number of cases reported at that time in 2004. There were approximately 3,000 cases during that first outbreak. And dengue has been confined or endemic to this area for around a decade. And then after 2013 through 2018, it has spread to areas sharing similar climatic and environmental conditions like that of Funsling. And the graph above shows the distribution of cases over a period of time from 2004 to 2018. There is no unique pattern. It actually fluctuates, as you can see in the graph. Now, talking about the rationale of the study, climate and environmental factors plays a crucial role in the transmission of dengue, although they are not directly involved in the transmission, but they actually facilitate the transmission of dengue. For instance, like freezing temperatures or extremely high temperature does not favor the transmission of dengue, as those conditions does not support the growth of mosquitoes. Transmission is also affected by the socio-demographic characteristics across different localities. Hence, understanding the local, spatial, and temporal pattern of dengue and recognizing the relationship between dengue and climatic variables are important to target public health control strategies. Hence, the objective of this study was to determine the spatial temporal pattern of dengue and quantify the relationship between dengue and environmental factors. Coming to analysis, we first calculated raw standardized morbidity ratio, SMR, for each sub-district by dividing the observed number of cases by the expected number of cases. Here we calculated expected number of cases by multiplying the national incidence by the total number of population in each sub-district. Then we conducted time series decomposition to obtain trend and seasonal pattern. R here is the residual, which is the leftover obtained after subtracting the trend and seasonal component from the data. Finally, we conducted a multivariate zero-inflated Poisson regression model in the Bayesian framework. The reason for choosing this zero-inflated Poisson regression over the normal Poisson regression is because of the excessive number of zeros contained in our data set, and also as determined by the statistical test known as Wong's test. So we found that multivariate zero-inflated Poisson regression actually is the most relevant model for our data. So when we design a Bayesian model, we always start with the probability distribution of the data of our interest. So in our study, we assume our data to be Poisson distributed with mean mu. Taking the logarithm of mean, we obtain logarithm of expected counts, and theta. Theta is nothing but the logarithm of the relative risk. And then we express this theta as a combination of these factors, which includes intercept, age, rainfall, temperature, humidity, NDVI. NDVI is the normalized different vegetation index, which indicates the measure of greenness. Higher the NDVI, higher the vegetation coverage, lower the NDVI, lower the vegetation coverage. Then we have V. V here refers to the structured random effect to model the spatial dependencies according to the neighborhood structure or adjacency matrix. So here we use this adjacency matrix to weight the areas. Like we gave 1 for contiguous neighbor and 0 for non-contiguous neighbor. Then we have the W, which is nothing but the spatial temporal random effect to model the spatial and temporal dependence on the data. And then finally, we have the leftover, which is the unstructured random effect. So for each of these parameters, we included a prior distribution. For intercept, we included the flat prior distribution. And for all the coefficients for age, rainfall, temperature, humidity, and NDVI, we used non-informative normal distribution with low precision. And then for random effect, we use non-informative gamma prior distribution. And all analysis, the zero-inflated Poisson regression analysis was conducted in the Winbox software. coming to the result, the map here shows the distribution of SMR across sub-districts. There is a wide variation of SMR across sub-district. There are 3 places which has high SMR as indicated in dark brown color. One here in the left is Samsi, this is Punseling, and the other one towards the east, I would say, is Dewathang. So these 3 places are also the point of entries between Bhutan and India. The graph here shows the seasonal and the trend pattern of the dengue. The first panel shows the distribution of data, raw data, and the second panel shows the seasonal pattern of dengue. So there is a clear peak occurring between between July and September every year, and this particular month corresponds to the monsoon season in Bhutan, which is characterized by heavy rainfall and higher temperature, which actually facilitates or favors the transmission of dengue. And then the third panel is the trend. There are peaks in 2017 and an apparent increase in trend in 2019. And this is one unique pattern of the transmission of dengue, that it actually fluctuates. Like every alternate years, there will be increase in the transmission of dengue. And the fourth panel is the residual. This is the main analysis, the main finding of our analysis. The first variable is age, which is a categorical variable. Those above 14, here we included them as the reference group, and below 14 as the risk group. As the relative risk and the 95% credible interval does not include 1, we can say that people who are below 14 are less likely to get dengue as compared to adults. The plausible reasons might be because the adults are more likely to engage in outdoor activities than children. And the second possible reason is because children are less likely to manifest symptoms, and therefore they are less likely to be reported. The other variable which is positively associated with dengue is the maximum temperature. Higher temperature decreases the extrinsic incubation period of the dengue virus in the mosquitoes and promotes the transmission. Higher temperature also supports the growth of mosquitoes. The temperature below, for instance, if the temperature is below 17 degrees centigrade, the mosquito ceases to feed and they won't survive. On the contrary, NDVI was negatively associated with the relative risk. Lower NDVI is associated with higher population density, which tends to favor the transmission of dengue. The map here shows the posterior means of the structured and the unstructured random effect. The first panel shows the posterior means of the structured random effect. It revealed that the places that are located in the eastern region has higher risk as compared to other areas, and there is a clear pattern. And the structured random effect revealed random distribution of risk. This is the trend analysis of the spatiotemporal random effect. The blue color indicates 50% chance of decreasing trend. The pink color indicates 50% chance of increasing trend. And red color indicates 95% chance of increasing trend. So there is only one area or sub-district which has the apparent increase in trend. And this is, as I've alluded earlier, this is the area that is located between, this place act as the point of entry between India and Bhutan. And adjacent to this area, we have this Indian town. So people actually migrate frequently to that area for shopping and buying some essentials. Perhaps, the frequent movement of people might have exposed people to get dengue. So in conclusion, there is an increasing trend of dengue with clear seasonal pattern observed between July and September. Temperature is positively associated, while NDVI was negatively associated with the transmission of dengue. High-risk areas found in the study can be used for targeting public health control strategies. Thank you.
Thank you, Chetan. Now we open question and answer session for Chetan. Is there anyone want to give some feedback or ask questions for him? Maybe I can start while we wait for others to join us. It's really interesting because from where I come from, Indonesia, it's also same with, I think it's same with Bhutan. Dengue is related with the season there. Why is dengue fluctuating? There is increase and decrease of cases in your graph, which you're in your presentation earlier.
Thank you, Andini, for asking this question. So dengue usually occurs as an outbreak. There will be an intensive transmission. So what happens during outbreak is that we implement, these massive public health strategies, like we remove the breeding habitats of mosquitoes. We spray insecticides, both thermal fogging and indoor residual spray. So those public health interventions, actually provide some protection for the population for a certain period of time. And the other possible reason is because during outbreaks, it is usually caused by one or two predominant serotypes, and most of the outbreaks are caused by one serotype. So what happens is you will develop a transient protection or a temporary protection to other dengue serotypes, which means that you remain susceptible to other dengue virus serotypes, because as you know that dengue virus serotypes, there are 4 dengue virus serotypes. So you still remain susceptible to other serotypes. So that's why there is fluctuation in the trend of dengue transmission.
Thank you, Chetan. Is there any more question from the participant? We have one from Jennifer.
Yes, hello. Can you hear me?
Yes.
Yes, Jennifer.
Okay, perfect. Look, as someone who's not at all familiar with dengue and spatial models, I'm interested in kind of the causal question. So I'm just sort of picking up on what you said about how those areas were points where populations move between Bhutan and India. So is it that what you're finding is that it's the kind of humidity and temperature and the other characteristics you had in those models that are predicting or that are causing dengue in those areas? Or is what you're finding that it's transmission from India and those areas are characterized by certain characteristics like humidity and temperature? Does that make sense?
Yeah. Thank you for asking this question. As you can see in the map that I have included only sub-districts that are located in the southern region, because all those areas actually has favorable climatic conditions, which includes rainfall, temperature, and humidity. But despite that, you also must have seen that some of the sub-districts actually they have low transmission of dengue, and few other areas they actually have high number of cases. Perhaps like you said, and also I have explained earlier, is because these areas are actually the point of entries between India and Bhutan, and we actually have a porous border. People from both countries can move freely without having to process your visa. So there's frequent migration of of people, and there is a policy failure, I would say, because for nearly 10 years, dengue was confined to that area. So they should have actually intervened the moment they actually detect the cases without, without actually spreading to other areas. Yeah. Is it? Sorry.
Okay, thank you, Jennifer, for the question. We have one more question here, actually. Shannon from Brett Lidbury. He can't speak at the moment. So, is migration of mosquitoes to the various provinces also a factor?
Yes, I think this is a very good question. So there was a survey conducted in 2000, perhaps in 2008 or 9, and they found out that that area, which I have highlighted in my presentation, so they actually have this Aedes aegypti, which is the main or the primary vector for dengue. 3 areas. One is Punseling, Samsi, and that Dewathang. But other areas, they have this Aedes albopictus, which also causes dengue, but it does not cause a very intensive transmission as that of Aedes aegypti. In 2019, we had one very severe outbreak. And for the first time, we detected Aedes aegypti in one area, which didn't have both the species, during the past years. But in 2019, that particular place actually reported Aedes aegypti, and there was a massive outbreak in that area. So they reported like around 80 to 90 cases, over a short period of time, and that actually surprised public health authorities. So what they did was they conducted the survey and they found out that there was Aedes aegypti. So this shows that the frequent movement of people, and when they are moving, they actually carry with them those mosquitoes. And then these mosquitoes actually breeds if the conditions are favorable.
Thank you, Shaban. Is there any more question from the participants?
Dini,
yeah.
There is a question in the chat from Lidbury, Brett.
Yes, I have read that, Ripon.
Okay.
And Shatan has already answered the question. So yeah, Brett commented again. Thank you. Yes, some species more effective at transmissions. Thank you, Brett. Now, I think we don't have any more questions from the participants. Thank you, Shatan, for your presentation. Now we will move to the next presenter and last presenter for this standard presentation. We have Tilahun Alamnia. Are you here, Tilahun?
I don't know that he is here, Andini. Sorry, I think he may be having some internet issues.
Oh yeah.
So yeah. I'm not sure what to do about that from your end. Okay. Whether to move on to the next or just wait a little bit, but he hasn't joined yet.
Yeah. Okay. Okay. Probably we'll just skip Tilahun for now, because our next schedule is actually for Professor Michael Kidd, but it's for 1:45 and he hasn't here yet. So I will continue to the next session with the 3-minute thesis format. We have, in the booklet we have Busayo, but he also have trouble with the internet connection. So we will have Sitan Ashati again. Sitan, are you here with us?
Yeah.
Okay, great. So Shitan will present on the application of machine learning models for spatial prediction of infectious disease. Time is yours, Shitan.
The warning is not yet.
Sorry. Apology for the inconvenience.
Sorry, Shitan, what did you say?
Let me play the recorded.
Oh, okay, yeah, sure.
Is that visible for you?
Yes, we can see it clearly.
Let me start.
The warning is not yet ready to meet the spread of emerging infection, which is evident in COVID-19 outbreak. The virus remains a global threat and a significant cause of this shows that understanding the future events is usually helpful. Design specific emergency.
Hello, Shitan, I can't hear the voice from your video. Shitan, are you there?
Andini, if there is any problem with the video, he can continue live as presenting only.
Yeah, we have Shitan again back with us. Shitan, do you want to try again with the video or do you want to present live? You can present live if you want. I think we lost him. Shitan, are you there?
Hello?
Yeah, Shitan.
Sorry.
No.
Sorry for, there are a lot of problems, especially internet connection. So can I play again?
Yeah,
sorry.
Please.
Sorry.
Yeah, no. Yeah, that's fine.
Is that works for you?
Yes.
The virus remains a global threat. This shows that understanding the future events is usually helpful. Design specific interface. To accomplish this task, machine learning algorithm can be leveraged to predict the geolocation of infectious disease. This is useful to deploy resources effectively and efficiently, thereby curbing the spread of epidemics. We can train machine learning algorithm using existing data or historical data and can develop predictive models. By using predictive models, can forecast future. This particular work, therefore, we have examined the utility and the model performance of three machine learning algorithms, namely artificial neural network, support vector machine, and random forest. They were successfully implemented in predicting the spatial distribution of infection like tuberculosis, HIV, malaria, dengue, fever, and other emerging viral diseases. Most recent one like COVID-19 and Zika. Moreover, entomologists also applied them to identify the risk area of vectors. Vectors for leishmaniasis, vector for schistosomiasis, vector for virus. In conclusion, the model accuracy of machine learning algorithm outweighs that of the conventional.
Sitten, I'm really sorry, but the sound is on and off, so we can't really hear your video. So probably you want to explain more in brief about your slide there. Just briefly explain about.
Okay.
Yeah, thank you. Sorry.
Sorry.
No, that's fine.
Yeah, yesterday I have attached the record video for, I think via email. I have attached it, and I assume that you'd play the record video, but now it's time is not actually comfortable. Anyway, let me brief what I have prepared for a 3-minute presentation, and the topic is actually to examine the application of machine learning algorithm for spatial prediction of infectious disease. And the systematic review focus on 3 major algorithms, particularly artificial neural network, support vector machine, and random forest. And we have investigated their performance and their application in order to predict the geolocation of the common or the prevalent infectious disease like tuberculosis, HIV, dengue, and other emerging viral diseases. And we have seen that the 3 algorithms showed powerful performance compared to the traditional models like regression and naive-Bayes and other conventional tools. And we have also examined their model performance, particularly using 3 indicators like accuracy, area under the curve, and we have also examined the R-squared value. And in general, the 3 algorithms showed, I would say, it's a decent performance. That's all about, the general goal of the systematic review.
Thank you, Sitten. Is there any question for Sitten or feedback or comments for his presentation? Let's see from the participant list. Thank you so much, Sitten, for your presentation.
Thank you.
Now we will have our external guest speaker. Today, we are lucky to have Professor Michael Kidd, AM, and after his talk, we will have a question and answer session. I will read his short biography that we've already got in the booklet. So Professor Michael Kidd, AM, is Deputy Chief Medical Officer and Principal Medical Advisor with the Australian Government Department of Health, and the Foundation Professor of Primary Care Reform at the Australian National University. He is past President of the Royal Australian College of General Practitioners, past President of the World Organization of Family Doctors, and former Dean of the Faculty of Medicine, Nursing and Health Sciences at Flinders University. Before returning to Australia at the start of the pandemic, he was Director of the World Health Organization Collaborating Center in Primary Care and Family Medicine and Chair of the Department of Family and Community Medicine at the University of Toronto. I think I've already seen Professor Michael Kidd here in the participant list. Good afternoon, Professor Kidd. Are you? Yeah.
I'm with you.
There you are.
Yes.
Yeah. Thank you. Please join me in welcome Professor Kidd. You have 15 minutes for the speech, and then we'll follow by question and answer session. Thank you.
Thank you, Andini, and thank you to everybody in the Research School of Population Health for inviting me to come and join you today. I'm sorry I haven't been able to be here through the morning and the early afternoon listening to all the presentations, but I did look through the list of the great diversity of research which people are carrying out as part of their student work with the school. And so I just want to congratulate you all for the work that you are doing. It'd be really helpful for me if everybody could pop your cameras on so I can actually see you all. Perfect, thank you. And I can see who's awake. I can see who got dressed this morning. It's great, thank you so much. Great to see you all. So I've been asked just to talk very briefly about some of the research work that we've been doing within the Australian Government Department of Health in response to the COVID-19 pandemic. And I also wanted to leave you with 4 messages, 4 lessons that I learned when I was a research student, which have helped me throughout my very long career. I completed my doctorate now nearly 30 years ago, so that was a very long time ago. So I came back to Australia from Canada in February of last year. I'd had conversations with Professor Brendan Murphy, who was the Chief Medical Officer. He's now the Secretary of the Department of Health, about coming back to Australia. And as soon as I arrived back in Australia, I was told, it's great to have you on board. We need a national primary care response to COVID-19. The Prime Minister 2 days ago launched a national plan for COVID-19, but we need a national primary care response. And I said, that's great, what have you got? And there was nothing. It was starting from scratch. So like a good researcher, I looked through the literature to find out what there was in the world's literature about the primary care response to pandemics and epidemics. And there was very little which had been published already. But what had been published, much of it had actually come from Toronto, the place where I had left 24 hours earlier to come to Australia. And the reason why there was research published in Toronto is because in 2002, during the first SARS pandemic, Toronto was one of the cities which had cases of SARS and deaths among the civilian population and also among healthcare workers. And there have been a number of reviews, royal commissions, which have been carried out following the original SARS pandemic of 2002, and a number of recommendations put forward. And fortunately, some of the public health researchers in Toronto had done some really good research on that original pandemic. So I took their work and we used that to form the basis for Australia's primary care response to COVID-19, and basically came up with 5 core principles from the research. And those principles were very simple. First principle was that there were people who were going to be more vulnerable to COVID-19, and these people were usually looked after by primary care. The elderly, people with chronic disease, people who are immune compromised, people living in residential aged care and disability care facilities. The second principle was the importance of separating people who had symptoms that were possibly COVID-19 from other people who were seeking healthcare, so that we didn't have people with COVID-19 infecting other people attending the same healthcare services. And as you probably know, we set up a number of respiratory centres to assess people with symptoms of COVID-19. The third important message was that whatever we did during the pandemic, we needed to make sure that people continued to have access to healthcare for other reasons, for acute medical problems, for the management of chronic conditions, for the management of mental health conditions, and for preventive care screening, especially for immunizations and for cancer and cardiovascular and diabetes screening. Because what the research showed was that often more people died from missing out on regular healthcare than died from the infectious agent. And we didn't want that happening in Australia. The fourth core message, key message, was that people working in healthcare services in the community needed and deserved the same level of protection against COVID-19 as people working in hospitals. This may seem really obvious to you, but in Australia in the past, when we've had past pandemics, including the influenza pandemic of about 10 years ago, the personal protective equipment was provided to people working in hospitals and emergency departments and wasn't provided to community nurses and pharmacists and general practitioners and allied health professionals, all of whom are just as much at risk of coming in contact with someone with COVID-19 as people working in hospitals. So we needed PPE for everybody. And the fifth principle was around mental health. And again, the research experience from past pandemics and epidemics showed that there was often a very long shadow, often going for years beyond the end of the pandemic, where people had significant mental health problems. People with anxiety, with depression, with eating disorders. And indeed, during a serious pandemic, the entire population would experience stress and distress due to isolation, loss of jobs, grieving over lost loved ones, all the things which we are currently experiencing with the lockdowns which we have in Canberra. So that was the research which informed developing that national plan. We then rolled out the national plan 2 days after bringing that all together. I was given 2 days to put it together. The Prime Minister announced $2.6 billion to spend on initiatives to support that primary care response to COVID-19. And then further increments of funding have come through over the last 18 months or so. One of the other things I did as soon as I arrived in Canberra was talk to Russell Gruen. Now, you all know Russell. He's our Dean. And I said to Russell, look, I'm really keen to do some research while we're rolling out health policy and new programs for the pandemic. Can I work with some researchers at ANU to do this? And I've had a wonderful team of researchers from ANU who have come into the Department of Health and have worked with me evaluating the programs which we've been carrying out rapid reviews of the medical literature to inform Australia's healthcare policy and our responses to the changing nature of COVID-19, and working with the policymakers, the bureaucrats in the Department of Health, in helping them to structure research questions to better be able to do the work that we do. Now, you may think that every piece of health policy in Australia is based on the best evidence, but often it's not. Often it's, Emily Banks is laughing. Often it's not. Often it's based on political whim. It's based on community pressure. It's based on pressure from stakeholders. It's based on what the electorate is saying they want to see. It's based on what media commentators are saying, whereas it should be based, wherever possible, of course, on research and research evidence. But one of the challenges we've got, just like the challenge I had in developing the national primary care response, is often people haven't done the research. or they've done the research and it hasn't been published. So it's been really important during this COVID-19 pandemic that we've been publishing our findings. The ANU team that I've been working with so far, we've published 15 papers on the COVID-19 response around primary care, mental health, aged care, occupational health, all sorts of different areas. The impact of COVID-19 on socioeconomically deprived communities, on culturally and linguistically diverse communities, the impact on palliative care provision, all sorts of areas. We have another 8 papers currently in press and 10 more under development. So it's been a great opportunity for researchers to do research on a topic which didn't exist 2 years ago. COVID-19 only appeared in December of 2019. So that brings me up to my messages for you. I've got 4 messages for you, which you might like to note down, things that I learned during my 30 years since graduating with my doctorate. And the first important message is to find your passion and then do research on that topic. What are you passionate about? What makes you excited about getting up in the morning? For me, it's been really easy over the past 18 months. It's been about how do we save the lives of people in our country during this pandemic? And what thinking do we need to be doing in order to protect the people of our country? That's a pretty good reason for getting up in the morning and for doing work and doing research. And if you find the things which you are passionate about, that makes you an even better researcher. So that's my first message. What are you passionate about? And do your research on those topics. The second is become a world expert. Now, what's the definition of a world expert? A world expert is someone who knows 5% more about a topic than everyone else in the room. That's it, 5% more. Everybody knows a whole lot, but you know 5% more, and you've got messages that you can share with others, and they'll go, I've never thought of that before. That's brilliant. Gosh, you're amazing. You can become a world expert. I became a world expert early on in my career in digital health because I was a bit of a nerd and I was really excited about the use of new technologies in improving the safety and quality of healthcare. And that's been one of the topics that I've been able to do research on with collaborators from all around the world, provide advice to governments all around the world, advice to the World Health Organization. But at all times, I probably only knew 5% more than everybody else. I then also became an expert on the management of HIV/AIDS in primary care, because that was the clinical area that I was working in when I graduated from medical school in the 1980s. It was a new disease, a new pandemic. But being involved in that pandemic, of course, has helped me to prepare for the career that I've got at the moment, responding to the current pandemic of COVID-19. My third message to you is when you're doing research, do research which makes a difference. Research which makes a difference in other people's lives. Often when you're putting together your CV for NHMRC and ARC grants, you're asked to reflect on how the research which you've done in the past has had an impact on policy or on practice. And this is research which has made a difference. If your research has influenced government policy and how we decide about spending our taxpayers' money, if your research has had an impact on clinical practice or public health practice and the decisions which are being made which affect the lives of all of us, then it's having an impact. That's research which makes a difference. So when you start your research, think about further down the track, once I've completed this research, how am I going to then share the findings so it can have an impact on policy and on practice? If you're lucky, like me and the members of my research team, to be working within the Department of Health, then your research is automatically going in to inform policy and inform changes in practice. The fourth message is something that I learned from Professor Peter Doherty. Do you know Peter Doherty? He won the Nobel Prize, Australian researcher won the Nobel Prize, and the Doherty Institute is named after him. The Doherty Institute has been doing a lot of the work, research work, particularly laboratory research work on COVID-19 in Australia. And I once invited him to come and give a talk to a group of my postgraduate students, my doctoral and master's students. And he said, the most important thing in your career as a researcher, this is from a Nobel Prize winner, the most important thing in your career as a researcher is to be generous. Be generous with other people. Be generous with your time. Be generous when you are coming up with a research idea about who you might involve in doing your research. Be generous on who you bring onto your research grants. Be generous when it comes to writing your papers, recognising that often the research you're writing in your papers isn't just your work, it's the work of a team. So be generous in the work that you do. And he also said that the people who get elected to the learned academies of science in Australia are people who are generous to other people. The people who are not generous, nobody elects them to do anything, nobody invites them to do anything. So it's a good message on behaving. You know, I'm sure you all behave appropriately and respectfully towards your colleagues, but also be generous to other people as well. So Andini, I might stop there, but I'm really happy to take any questions that anyone might have.
Yes, thank you, Professor Kit. Now for question and answer session. Is there any question from the participants here?
Nothing is off limits.
Okay. Now, we have question from Emily. Please, Emily.
I might defer to the student first, and I'll ask my question second.
I don't have from students at the moment, so
I might have a question.
Oh yeah, Katrina. Sorry, I didn't see you. Please, Katrina.
Hello, Professor Kidd. My name's Katrina Howe. I'm actually a Commonwealth Department of Health employee on a Sir Roland Wilson scholarship here at the ANU. And I was just wondering whether you think that your time with the team from ANU in the Department of Health has shown the Department of Health the benefits of using research and evidence to base policy decisions on.
Thanks, Katrina. It's a great question, and you could probably give a talk on your past experience on whether that has or hasn't happened before. I think it has, and at the very highest level. The person who's been supporting the work that I've been doing with my team has been the Secretary of the Department, Professor Brendan Murphy, and he's been reading the papers which the team have been writing. He's been encouraging people from across the department to get engaged with the research team. But it hasn't happened easily. You know, the first few months, the researchers from ANU found that nobody would talk to them. People were worried about confidentiality. It wasn't until they became accepted as a part of the team that was working particularly initially on the primary care responses and then the other areas of work that we've been doing, that people started to open up and be willing to work with these research colleagues. There are a lot of people with strong research skills in the Australian Government Department of Health. Lots of the staff have master's degrees, many of them have doctorates, many of them have links to ANU or to other universities. I think that we need to be continuing to build that up. And obviously, through the work that I do, I'd like to see us doing more work, having our policies informed by evidence wherever possible. Thanks, Katrina. Andini, I think we also have Hari Bondu with you.
Yes, Hari Bondu Sarma. Please, Sarma.
Okay, thank you, Andini. It's actually nice to hear from you, Michael. I'm an early career researcher here at the Research Institute of Population Health. And I came from Bangladesh I had a quite extensive research experience in low-income settings, and I am trying to learn the Australian health systems as well as how it's work. So my questions to you, since you also came from the other settings and started your work here in Australia, so how difficult it is for you to adjust with this Australian research context, and how easy for you? Both of these. Can you please?
Thanks, Harigundu. It's a great question. What I've found, because in my career, I trained in Australia, and then I've worked in different settings overseas. And often when you go into a new research setting, it takes a few years before you find your feet. And often I've found when I've gone to a new country, the first couple of years I've been developing new collaborations, new partnerships, coming up with new research ideas, which are going to be relevant to the context of that country. And at the same time, I've been writing up research from the previous 2 years from the country that I've come from. So it's kind of like being on a bit of a conveyor belt. But there is definitely a learning period and a time when you need to be spending a lot of time listening and a lot of time reaching out to other people. And one of the things I do first when I go into a new country or a new setting or a new institution is to talk to people who have similar interests to mine, and then ask them, who else do you think I should be talking to? And I go and I visit people and I meet people, and that's incredibly helpful because it builds up your network very, very quickly. Now, often you'll have people who you know in the new setting you go to, people you've met at conferences, people who you may have collaborated with on international research in the past. But building up that network of people, and then these will be people who you'll be working with throughout the rest of your career. And so take the time, but also listen to people and listen to what are the key challenges in the new setting you're moving into.
Thank you.
Thank you. We have one more question from Uday and Yadav.
Yeah, hi, Professor Michael. Thank you very much for your inspiring talk. I'm Uday, and I recently joined NU as a research fellow, and I'm an early career researcher. I really like your strategy that you mentioned to engage the policymakers in the, policy in the research. And I used the similar strategy when I was back in Nepal and in some of the developing countries. And I feel like it's not impossible. It's really possible. And I want to because you work in the different developed setting. So how do you engage the general practice and in the research? So because I was just looking at your profile and you are published many things. So I just want to know what is the strategy to engage the general practitioners, and how do you address power balances between the bureaucrats and the general practice or the other stakeholders in academic work, particularly in the research?
Thank you. Thanks, Uday. Great question. So there's probably two levels of engagement. The first is to find the champions. Who are the research champions in the area that you're interested in? So if I was, and I've been to Nepal several times, I was working there and I was wanting to do primary care research, I'd find out who are the champions, who is the professor of primary care research at the Kathmandu University, for example, or the professors in the institution which I had my links to. Engaging with actual practitioners happens at a number of levels as well, because we have practitioners who are very keen on research and different levels down to those who have no interest at all. So engaging those who are really keen. So you will have general practitioners, for example, in Australia, we have GPs who are researchers, who have PhDs, who are doing research in their practices. So we get involved with them. We have an academic association of the Australian Association of Academic Primary Care, which brings all those people together. So everybody knows each other. Then we have practices which are willing to have research carried out in their practice. They may not want to do the research themselves, but they're willing to be partners with academic researchers. And then we have those who aren't terribly interested, but we may still be able to get them involved in research through some of the work that we're doing, particularly looking at the findings out of electronic medical records. So at the moment, we have projects in Australia to bring the details of electronic medical records in general practice together at a regional level and then at a national level to allow us to better understand healthcare and healthcare challenges in general practice in our country. So there's a bunch of different levels that you can aim at.
Thank you very much.
And Dini, did we want to go back to Emily?
Yes, please. I think we've already done all the questions from
absolutely. It's absolutely fine. I know that we're running short of time, so it's completely fine. I was really going to ask a very similar question to Uday, which was really for people at the beginning. A lot of people sort of junior researchers are thinking, well, how do I engage with policy? What are the first steps that I can take? Because it does feel a bit like a sort of huge kind of monolith, you know, the health department. Where do you go? What do you do? So that was me, but I think you've really addressed quite a lot of that already, Michael. Thank you.
Yeah, thanks, Emily. I think that reach out to other people. So reach out to the people who are the academics at ANU who are doing research in the area that you are interested in. Find out what you're passionate about and then try and find a more senior person who shares that passion. One of the things we love as professors is when students contact us and say, I'm really interested in your research and can I come and have a talk to you about it? We love talking about our research. So find the people who are involved in the area that you're involved in. And chances are they will know the people in the Australian Government Department of Health or the ACT Department of Health who are involved in policy in that area. And if you can't find them, reach out to me and ask me, who's working in the Department of Health who's interested in this particular field? Can you provide me with an introduction? I'll provide you with an introduction and then it's up to you. Reach out to that person. And if you do reach out to a senior academic, look them in the eye and listen intently to what they have to say and take lots of notes, because we love that too, because it shows that you're listening and you're interested in what we've got to say.
Thank you so much, Professor Kit. Is there any more question from or feedback from the participants? I don't think we have. So thank you so much for your valuable time, Professor. So it's very useful, at least for myself, with the lesson that you've already shared with us today. Thank you so much. And we will continue to the next session because we're a bit running out of time here. We have Tilahun back with us. So are you here now, Tilahun?
Yes, I'm here and I'm ready to.
Okay, please prepare your slides.
Okay.
Okay, you have 10 minutes for presentation and then we will have a couple of minutes for discussion. Thank you.
Okay, thank you very much. I'll present a preliminary finding on non-communicable disease risk factors in Bahar Dar, Ethiopia. As introduced before, my name is Tilahun and Dr. Mati and Dr. Jini are my supervisors. This is the rough presentation outline. It will include introduction, methods, results, and challenges. As an introduction, as we all know, non-communicable diseases are chronic conditions such as cardiovascular diseases and diabetes mellitus, which are associated with personal lifestyles. And they are mostly a major burden of diseases throughout the world. Despite this, they affected disproportionately low and middle income countries, as we see.
Sorry, Tilahun, can you please do a slideshow? We still can't see. Can you click the...
Is the slide is not okay still?
We can see, but into the slideshow in the right bottom corner.
Okay, I can make it again.
Yeah.
Yeah.
Okay, that's fine.
Is that fine now?
Yeah, that's fine. Okay, Tilahan.
Okay. So, non-communicable diseases are chronic conditions which affected more disproportionately in low and middle income countries such as sub-Saharan African regions. The 21st century has brought a lot of changes in human life associated with globalization and technology advancement. Despite this, the high burden of non-communicable diseases become a major health burden throughout the world. When you see non-communicable disease situations in Ethiopia, Ethiopia has encountered a rapid increase in the prevalence of non-communicable diseases during the past few years, associated with changes in political situations, economy, and social changes. Currently, WHO has estimated around 43% of the disease burden in the country is due to non-communicable diseases. Despite this prevalence is lower than other countries, the rate of increment is high when you compare it with the rates in other developed regions. There are different challenges in preventing and controlling non-communicable diseases in Ethiopia, including poor literacy of non-communicable diseases among the policymakers and the community, lack of trained human power in the field, and shortage of staffs. In addition, the high burden of infectious diseases, that means double burden of diseases, making the health system response more challenging and sophisticated. Using these premises, we developed a research question to conduct surveys and do qualitative researches in the study area to understand people's awareness about non-communicable diseases and prevalence of non-communicable disease risk factors and socio-demographic determinants, and as well to understand the existing perception and beliefs and experiences about non-communicable diseases in Bahir Dar, Ethiopia, and as well in primary healthcare providers. But for this presentation, I will only focus on the first objective. This study was conducted in Bahir Dar, Ethiopia. Bahir Dar is a city in the northwest part of Ethiopia, having more than 500,000 population, and it is among the populous and rapidly growing city in Ethiopia. Besides, it is my hometown. Now I will talk about the methodology that we used to collect data in our survey. This was a quantitative survey conducted among adults, and we used single population proportion formula to determine sample sizes. Interviews were the main method of data collection because the adult literacy level in the country was low. It was estimated to be around 52% based on the World Bank report. Data collectors were nurses. We prefer health professionals as data collectors because they are professional and socially accepted member of the community to conduct measurements and advise the results accordingly. For example, for hypertension, we mainly focus to measure prevalences of non-communicable disease risk factors and associated issues in our survey. We have used various strategies to increase the quality of our data. First, we translate into local language and we give training for data collectors. And we have conducted a close supervision until the end of the data collection. And I daily checked the collected data for completeness and consistency. Currently, I have entered the data using Epidata software and I am analyzing using SPSS software. This is the preliminary result and sample socio-demographic characteristics of participants in the study area. As we see from this table, most participants were between the ages of 18 and 13 years old. and more than half of participants attended vocational and tertiary level education. This is due to the study area is ICT. With regard to healthcare afford and healthcare insurance, only 1/5 of the participants reported they do have health insurance, others not. This graph shows the neurology and attitude of participants about non-communicable diseases and risk factors prevention. The blue bar indicates neurology level and the red their attitudes. As I understand from this graph, most participants have optimal level of neurology about non-communicable disease preventions, despite the neurology has some gaps. And when you see the actual distribution of risk factors in the community by observing this chart, I can say that the community is highly risk for developing non-communicable diseases. For example, less than 10% of participants has adequate intake of fruits and vegetable intake, and more than 50% of participants used alcohol. And the new finding here is that nearly 40% of participants reported they do have some mental health problem, which may be associated with the current political situations and instabilities in the country. Actually, it is high. This table shows the distribution of overweight and obesity in the study area. Nearly 1/3 of participants, or 30% of participants, were overweight and obese. Overweight and obesity were associated with women than men, and high blood pressure were reported in 21% of the participants. This didn't show any relationship with the gender of the participants. And finally, we conducted a bivariate logistic regression analysis to indicate the predictors of overweight and obesity and for hypertension. First, we conducted bivariate analysis to select variables, and then we adjusted in the multivariate logistic regression analysis. Finally, age of participants, sex, occupation, waist to height ratio, and blood pressure levels were predictors for the high prevalence of overweight and obesity in the study area, while salt use, hypertension screening behavior, and body mass index were final predictors for the high prevalence of hypertension in the study area. I have encountered a lot of challenges during the survey. This was collected during the global COVID-19 pandemics. As well, there was a national crisis in the country. In addition, the data collection period was overlapped with the Ethiopian election day, which has caused some disruption in my data collection. Besides, most of the participants in the study area didn't appreciate the importance of the research. They asked me, many researchers have done researches before, but they didn't come up with findings and policy solutions. So what is different for you? I have encountered such type of questions in many participants. As I mentioned earlier, I do have qualitative interviews with primary healthcare providers and interviews in addition to the quantitative survey, and I plan to present my findings in 5 chapters, as it is shown here. In short, this is the overall summary of my survey study. Thank you very much. If you have any questions and comments, I'm happy to receive it. Thank you very much.
Thank you, Tilahun. Now we open the question and answer session for Tilahun's presentation. Is there any question for Tilahun? I didn't see any hands raised up here. Okay, we have one question from Lindell. Please, Lindell.
Thank you very much, Tilahan. A very interesting project you're doing. What occurred to me was how some of these risk factors are probably co-occurring and affecting multiple of the disease outcomes you're interested in. And mental health would be, in my mind, mental health is a non-communicable disease. But it's going to be it is very responsive to particularly physical activity and other alcohol use, a whole lot of other factors. So there's going to be a lot of connections going on between the different sort of risk factors and diseases you're looking at. And I'm interested in that and what you think that will look like in the community you're studying and how you might think about that in the way you approach your analysis.
Okay, thank you very much. We have, as I told you before, it is a preliminary stage. We didn't go with higher analysis to determine specific predictors for high mental health problems in the study area. But currently Ethiopia is facing political chaos. There is instability, displacements across the borders of the country that might have increased the prevalence of mental health problems in the region. But when we go through the detailed analysis, we'll come up with specific predictors for this high prevalence in the study area.
Okay. Thank you, Tilahun. Is there any other question for Tilahun? Okay. I think that's all for today, Tilahun. Thank you so much for joining us from Ethiopia.
Thank you very much. Thank you.
Now we will continue to the next session. So the next session would be, we've already done the 3 minutes oral presentation. Now we're going to have, well, actually for this year's conference, we have photo competition, but unfortunately we only had 1 submission, and we're lucky to have Cynthia Parayiwa. Are you here with us?
Yes, I'm here. Thank you.
Okay, thank you. Can you share your photo and then briefly explain your photo to us?
Yeah, no, of course. I won't take too much of anybody's time given how we're running, but thank you for the opportunity to share it. Let me get that going. Okay, so definitely appreciate the opportunity and thank you to the RSPH Student Conference Committee for having me. So I'm actually based at the School of Archaeology, so I snuck in through a back door, but really loved all the presentations and very interesting work happening there. My project looks at the experiences of mothers during cyclone disasters. So I'm actually really interested in environmental health, and that's where the overlap happens. And I have some of my panel sitting within RSPH. The photo that I submitted here was just looking at how COVID-19 and the pandemic that happened last year and is ongoing at the moment affected my research particularly, as it obviously affected to some degree everybody's work. As part of the mixed methods approach that I'm taking to my PhD project, I had a qualitative component where I was hoping to actually capture the individual experiences of mothers who have been pregnant during cyclone events, despite the category level, just to really capture how they either have certain resilience factors or certain vulnerabilities that would be of interest when kind of looking at building strategies and building risk management policies. With these interviews, when I did start the conceptualization for them, so putting through the ethics, they were already quite a sensitive area to be trying to do qualitative interviews in, because you're thinking about women who are retrospectively thinking about potentially traumatic events, and they're already a vulnerable group as we are speaking to mothers. And if there's anything within the mental health sphere, so you're thinking about the trauma itself, but also potentially pregnancy loss or any other health complications associated with the experience. So we spent quite a lot of time making sure we're catering to anybody who did volunteer into our research project. When the pandemic then came along though, and this was already when we had begun our recruitment, we had to very quickly adapt and maintain that sensitivity around the content and the material that we were collecting, and obviously looking out for the mothers who were opting in to provide that. So this photo is at the very beginning of that. It's quite cheerful for someone launching into research work. But what I was doing here is you can actually see a couple of the strategies that we did try and implement to ensure that we're looking out for our participants. So this is prioritizing participant confidentiality beyond what we had proposed within our ethics applications, because we had to make this adaptation to a virtual delivery of these interviews. So you're thinking about making sure they're aware of what they're opting into and how it might vary from a normal interview setup. If they're comfortable with using a virtual platform, they're comfortable with the recordings and understanding how we're going to be using those recordings for only transcription purposes, same as if it was in person. Carefully selecting locations. I did it for the library in the case, to ensure the backdrops and no walk-ins from anybody else interrupting any of our interviews, and monitoring audio and video outputs. So for example, using earphones to ensure anything a mother is sharing with myself would remain confidential, and also striving for my video to be on just to, there's quite a lot that goes around making sure the participant does feel comfortable within whichever format that you are conducting your interviews in. And this was just one way we could attempt to do that, but keeping this optional for the participants themselves. So if they did not feel comfortable using interview on their end, that was completely fine. Thank you, everyone. That's it.
Thank you, Cynthia.
That's okay.
Is there any comment for Cynthia? Comment or feedback? Okay, we only have claps from there. Okay, thank you for sharing your journey with us, Cynthia.
Yeah, that's fine, thank you.
Obviously, we are all adapting to this new normal, including us with organizing this, the first virtual student conference here. Okay, so with that, I will now return the session to Ripon, who will moderate the final session. Thank you, Ripon. Over to you.
Thank you, Andini, for doing the sessions smoothly. In this stage, we will take few minutes for calculating the scores for announcing the rank, though it is not, the conference is not for that rank or winner. But yes, we, as you said, we have to do that. So it will take few minutes. In this stage, I would like to invite Lyndall for giving her closing speech. In the meantime, when we have the score, we will let Lyndall know the names of the winners, and probably she will announce at the end of his speech. Please, Lyndall, you can start the closing sessions.
Okay, thank you, Ripon, and thank you actually again.